Good morning. My name is Joy Hoskins. I'm the Director of Nursing for the Kentucky Department for Public Health. Welcome to today's Public Health Nursing webinar. Today is December 13th, 2018, and I hope where you are today, you've got your Christmas decorations all up, and you're having your gatherings, your family gatherings and your work gatherings to celebrate the season. It's really warm here today, balmy today, so it doesn't really feel like Christmas as far as the season, but I know Eastern Kentucky has really had some snow and ice down your way, so I hope you all are safe and warm where you are. We're going to go ahead and get started today with Trina Miller, who is the prenatal program coordinator for the Maternal Child Health Division, and she's going to be speaking with us just briefly to update you on a new initiative called the 17 PPP. The effort is to reduce preterm births, and so we're so excited to have Trina here today. She does a lot across the state. Many of you all have worked with Trina, know Trina, on her efforts to promote healthy prenatal outcomes both for mom and baby. So we're glad to have her with us here today, Trina. If you want to come on up.
Good morning. I'm Trina Miller, and I'm with the Division for Maternal Child Health, and I'm our prenatal program coordinator. And so I'm excited to talk to you this morning briefly about a new initiative that we're going to be starting.
Let's see, we're going to find it.
That is for helping to prevent premature births. And so this information, if you have any questions about this, you can feel free to contact me. My contact information is at the end of the PowerPoint. So anyhow, we'll get started then. So one thing that we know is that premature births and its complications are the largest contributors to infant death in the U.S. And it's a major cause of long-term health problems in children who do survive. The prenatal program and the Department for Public Health has had a long-standing relationship with the March of Dimes. And so we have a new initiative that we're going to be working on with them. So I know all of our people that have kids, they get report cards. And so we also get a report card with the March of Dimes. And so how this is done is what they do is they are looking at our 2017 data, and they are comparing that preterm birth rate to the March Dimes goal for the 2020 goal, which is 8.1%. So they're comparing our data with that 2020 goal of 8.1%. And so when they report that out on our report card, unfortunately, our letter grade is a D. But from here forward, we're going to have some good news to share. So we'll start off with this, but then we're going to move forward. I'm going to talk to you about how we can do some efforts to improve our prematurity birth rate. You see here our preterm birth rate for Kentucky is 11.1%. When we look at over this past decade here or so, looking back in 2007, we were at 12.7%, and we can see that that rate dropped down into the 11% range, and even down in 2014, 2015, in that time frame, we were looking at 10%. And then the past 2 years, we've climbed back up. We went up to 11.4 in 2017, 11.1%. And so we want to continue to work on efforts to decrease this preterm birth rate. And we want to talk a little bit about that this morning. Here's a little bit more information from March of Dimes, looking at the preterm birth rate. This is the average 2014, 2016 by race. And so you can see a little bit here of what that is showing us here. So then moving forward, I want to talk about the 17P PP, as Joy very well said that acronym out, but it's our 17P prematurity project. So what we have is we have received a March of Dimes grant, the Maternal and Child Health Division, that was funded by Anthem to give a small amount of funding so that we can provide the health departments with materials to distribute to pregnant women. And I'm very pleased with the materials that they have and that we're going to put in packets that can be distributed to women. Very nicely done and will be very beneficial and useful for our women in our communities. The purpose of this initiative is to increase awareness and the use of hydroxyprogesterone, which is 17P. So we'll refer to 17P, it's a little bit easier to say. And what that does is that helps to reduce preterm birth for women of childbearing age who have a previous history of preterm birth. The goals is that we want to reach women of childbearing age who have a previous preterm delivery with information about 17P, and we want to increase the number of women given 17P information prior to the projected 15th week of pregnancy. And I'll talk a moment about why that 15th week is so important in regards to 17P. So the eligibility for women to receive 17P, because there is a time frame or a window for it to be effective. Progesterone is a hormone that helps the uterus to grow during pregnancy and also helps to prevent contractions, two very vital processes that need to happen in order to have a healthy pregnancy and to have a full-term pregnancy. For women who've had a prior premature birth, which means before the 37th week of pregnancy, progesterone shots called 17P can help to prevent another premature birth if. So there have to be these next two qualifiers for the 17P to be effective. The March of Dimes has a pamphlet handout that does a very good job of explaining this in very simple, easy to understand information. But these two qualifiers are the woman had a spontaneous premature birth while pregnant with just one baby prior. So she wasn't induced or she just had a spontaneous premature birth. So before 37 weeks, it was only pregnant with one baby and then her prior pregnancy. And then currently she is only pregnant with one baby. Studies show that 17P does not show to be effective in women who are pregnant with more than one baby. So she needs to be pregnant with just one baby. So the shots should begin between the 16th and the 24 weeks of pregnancy. And then after they start, they'll get a weekly injection until 37 weeks. So we want to be able to identify women before they get to that 16th week in order to try to maximize that time frame to get them the information. And so when they go to the doctors, they can check and ask about this 17P. If a woman is identified and it's after that 15th week, she may come in and it's after the 15th week and she finds out she's pregnant. She could still then get the 17P, but hopefully we're getting women in and they're getting their pregnancy test done early, and we're getting them to the link to a doctor. And so if it's we can get the information in their hands before the 15th week, then the earlier they start that, beginning with that 16th week, that will be more ideal. So what we want to do, MCH, we want to invite you to join us by providing pregnant women with information that can help prevent preterm birth in your community. We want to help prevent these small premature babies from being born so early and to help them have a healthy start on their new beginnings, and to help our moms have a healthy pregnancy that can go to full term. And so we're going to do make this very simple and easy process just in order to equip you with information to hand out to women. So what we'll be doing here at MCH is that I'll give a little more information and brief training and some instructions just to help with some of the mechanics of identifying when women should get the information or the package. We'll here at MCH will be purchasing all the information and materials, packaging of all the materials, or I'll send them out to the health departments in pre-packaged and postage paid materials. And that way the health departments, you can just distribute them to women that come into your health department that would fit that criteria. Or if you would need us to, and you would like to give us the information with who to send these to, we could also assist you in that way to send the information out to the women that come into your health department that these should go to. And we'll be completing all the grant reporting and working with the March of Dimes for that. What we'd like your help with in the health departments is that we will be having a 5 to 6 question survey that we'll give out, send out to those health departments that want to participate in this. And that way, and then one at the end, a survey at the end, just to see if this initiative also helped yourselves learn more information and become more aware about 17P and how it can help prevent prematurity. And then if we would like, if you're able to send that to your local providers, maybe that you contract with or send women to, that way they'll be able to know if they've also learned a little more about the awareness process with 17P. We'd ask that if you're able to mail out or hand out at the health department these prepaid 17P packets of the educational material to the women. And if that may be a little too cumbersome, like I said, we can always help and assist with that here. If you're able to give us the name and information, then I'll be sure to take care of that we get those sent out to those women. We want to partner with you and make this as easy of a process to help you in your community to make a difference with our pregnant women and our healthy babies. And then we'll just ask that at the end of the time when we work on this initiative, it's just to let us know how many packages that you sent out or gave out. And so we'll have a starting number we gave you, and however many is left that you didn't send out, then we can do some easy math that way for that purpose. Something that may be helpful, and I'll go a little over this a little bit more. We do some training for those health departments that want to do this, is that there's a place when you have the positive pregnancy test that lists the EDC. So you may want to, on that spot, is just to indicate when that projected 15th week would be. When you're using the little wheel and you find out what their EDC is, you can easily look and see where it says the 15th week, mark that date, and that may be something to help you. Or there may be an easier way that within your health department or within your pregnancy test that you're doing, that you may want to make a note or a memo or such. So whatever works best for you, but this may be a way that is helpful. So this is the exciting part. I love materials and education. If I wasn't a nurse, I said I want to be a school teacher. But as a nurse, we always get to educate, which is great. And so I'm excited about the material that we have here. On the one purple sheet is the March of Dimes material, and I just put a snapshot here. But every health department will be getting a packet with some information in it, and those who want to participate will give you much more packages of materials that you can then utilize and give out. But this are the progesterone shots right for you. One side is English and the other side is Spanish, and it actually lists on there, which make it, oh, I just spun my cursor there a little. It kind of like Wheel of Fortune gave it a spin. But we're back now. So anyhow, oh, I thought I was on a game show for a second. Yeah. So these this fact sheet here, our progesterone shots right for you, is really great because basically those two qualifiers I said, have you had a premature birth prior with one pregnancy? It states it right there, right there on that sheet. And the woman can just check it. If she gets this, she can like, oh, that does apply. It has a little checkbox. And then it says that you're pregnant with just one baby currently, and she can check that if that applies. And on there it talks a little bit in just some really easy language of what progesterone is and how it helps. And it gives you the reminder sheets that says at the bottom, which you can't see there, but it says find out if 17P is right for you. And it says, have you had a premature birth in the past before 37 weeks? Were you pregnant with just one baby? Was your labor spontaneous? Did it start on its own? And are you pregnant with just one baby now? And if they answer yes to all those questions, it tells them to ask their provider about how to get progesterone shots. And so it gives some very easy information. It gives a little video site on March of Dimes to watch that talks about progesterone. And they're very colorful and easy to read. And then, like I said, one side's English, one side's Spanish. The other item that's on the screen is a magazine called My 9 Months. And this is a magazine that we'll also hand out, or we'll put in the packet for you to hand out. And the one side of the magazine is English and one side of the magazine is Spanish. And so it goes through month by month, what to expect, how the baby's developing, what's happening to your body. It talks them about prematurity and preventing prematurity. It gives some little journaling stuff in there to be interactive for the woman and help to engage her. It goes all the way through prenatal care, through the baby growing, through the mother's changes, all the way to labor and delivery and breastfeeding and postpartum depression. So the kind of full gamut, and it's for both of our English and Spanish populations, the language is in. So I think those are very exciting, and we want to make sure to get those in your hands for everybody to be able to look at and to utilize. So I want you to have a little thought and ponder on this after the fact, and let me know if you're interested in participating. I'll send a prepaid and prepackaged envelopes with this material in the mail. Like I said, everyone will get some, but then if you are interested in doing this, then we'll be sure to send plenty so that I'll kind of look at how many pregnancy tests you generally do. And of course, we know women don't always follow the same as they did last year, but we'll be able to start you off with plenty of materials to get started. So thank you so much for your time, and thank you for what you do for moms and babies. I was a labor and delivery nurse for many years prior to coming here, and so moms and babies are special to my heart, and I'm always thankful for all that we do for everyone in Kentucky, but I'm thankful for all that you do for moms and babies, and I appreciate you being involved in this if you're able. Thank you.
I've got a question.
Oh, yes.
Trina. So for a local health department who may not be providing prenatal services directly on site, would you encourage them to provide the packages through through WIC and so talk and hands and maybe they're subcontracted prenatal providers?
Oh yes, because this is something that every health department could do, even if you don't have a prenatal clinic on site, because we don't have that do that services on site, but we're still having pregnant women come into the clinic, whether it be for WIC or hands or getting pregnancy tests. So this is something that, because it's an education piece and not a clinical piece, every health department can do and work into their workflow. And so certainly there's if there's ways you're not sure how it might work in your health department, I can help you with that. But it's something that everyone can do, and we want to make it as easy as we can for everyone to participate and reap the benefit in your community.
Thank you, Trina.
Thank you.
Okay. So while Jamie gets us switched over, thank you, Jamie. I'll invite Bethlyn to come on up. Bethlyn Shepard is the lead prevention program epidemiologist, and she's here with us today to talk about data collection, basics of testing, follow-up, and so we're glad to have her here today. She is going to be our nursing CE presentation today. This presentation was approved for 1.0 nursing CEs. So thank you very much, Bethlyn, for being here with us today and providing us important information about lead poisoning prevention. Thank you.
I think I can see my slides, or do they see?
Right now, both.
Oh, great.
Yeah. So Bethlyn's happy that you'll be able, just so you'll know, Bethlyn is very happy that you'll get to see her and her slides this morning. Not.
It was my word, Matt.
There you go.
Thank you.
Thank you.
Am I in front of it, everything?
Yeah, you're doing good.
Okay.
Your camera's right here for you.
Okay, awesome. So as Joy mentioned, I'm the program epidemiologist, and I'm also wearing the hat of everything the nurse would do since we lost our nurse back in April, but we are working to replace that position, and it seems to be going fine with just me at the ropes. So today I'm going to cover some basics of testing and follow-up for childhood lead testing, and then a brief little bit about pregnant women as well. So here are some of the objectives for today's educational material. So the first section is about lead basics, just some background information. I apologize if this is something most of you know, but we get new nurses all the time, and it's best to try to cover all bases just so that they are up to speed. So lead is a naturally occurring heavy metal, and it can be found in small, typically trace amounts in our environment and the Earth's surface. And most of our exposure is the result of anthropomorphic interventions, meaning humans took lead to make something or to do something, and then it causes us to get exposed. And it exists in all aspects of our environment, air, soil, and water. And our main routes of exposure tend to be inhalation, so breathing in lead dust, and ingestion, so consuming it in some way. So why is lead harmful? Lead is especially harmful to children because our bodies treat it as calcium. We don't know what to do with it, and that's how it gets metabolized and stored. Young children need more calcium, and therefore their bodies tend to retain more of that lead than adult bodies do because a grown body doesn't need as much calcium. Lead is also more of an issue for young children because they tend to spend more time in close proximity to sources of lead dust, such as crawling on the floor, holding on to windowsills or the walls when they're learning to walk, and playing on the ground outside, so getting in dirt more than an adult normally would. They're also at a higher risk because of the way they explore their environments. You know, if you give a young child any toy or, keys or a cell phone, they're going to put it in their mouth first. And if that's covered in lead dust, we have something that is not harmful, but it's covered in a toxin. So it can really show up in very obscure inanimate objects. And we have had issues with cell phones where adults work with lead dust, and the cell phone becomes kind of that carrier for the exposure. So symptoms of lead exposure is not something that we want to emphasize to patients or to the parents because it doesn't typically have a symptom, a visible symptom, unless a patient's blood lead has already reached very dangerous levels. There are exceptions to the rule. You might have pretty low exposures where they're having some symptoms. But because of the unreliability of the presence of symptoms, we don't want to emphasize it. But when possible, it is nice to remind parents of this because, as I'm sure most of you know, when we don't feel well, our family member gets diagnosed with something, we hear about the new strain of flu, what do? We go to Google and we look for symptoms. And we don't want our parents who are coming in to get lead tested for their children to do that and think that they're fine. They don't need to have a lead test. They don't have any of the symptoms because that's just not how lead works. So here are some of the effects of lead broken down by children and pregnant women. These range from mild behavior or learning disabilities caused by the neurotoxin of lead, and then they can range up to death, coma, seizures, stomach issues is one that I don't think is on there, but that's probably the more common one I've ever seen in really high exposures. And then pregnant women, this tends to be a risk for the fetus more so than the mother because it can affect the baby's brain, kidney, and nervous system, and it can cause low birth weight and possibly miscarriages. So in this section, we'll cover who gets tested for lead and different testing options available. I realize I might be addressing some topics that most of our local health department nurses are very familiar with, but sometimes you are the only point of contact for the many, many providers' offices we have around the state who do lead testing. Currently, only about 7% of our lead tests statewide occur in a health department, so that leaves hundreds, maybe thousands of providers' offices doing it. So if you ever get a test from a facility and something has been done incorrectly, an artificial elevation, maybe they're just not reporting it properly to you, you might be the one providing education for them. And if you're not comfortable with that, you can get with me and I'll take over because I deal with lead every day. It might be easier for me to educate someone, but I still want you all to know these aspects where things go wrong, and nurses in private pediatric offices are just not as reachable as you all are to us. So when to test children for lead? This is broken down into two categories. We think of them in their Medicaid enrollment status. So a child that is not enrolled in Medicaid should be tested annually based on responses to the verbal risk assessment. If the guardian responds to any question with a yes or I don't know response, that should result in a test. And this should continue until they are 6 years old. So ideally we would test a child 5 times between ages 1 and 6. If a child is enrolled in Medicaid, they are required to be tested at ages 1 and 2. This test has no bearing on a verbal risk assessment responses because being Medicaid enrolled means they are automatically considered high risk for lead exposure. They're the low income populations. They're going to be the ones most likely residing in low income housing that's not being maintained properly. So for testing pregnant women, this should also be based on their responses to the verbal risk assessment. And this ideally is meant to be completed at their first prenatal visit, but that doesn't always happen for various reasons. It's also especially important to get a pregnant woman tested if she has an existing child that has a lead exposure, because she's likely experiencing the same exposure and we don't want that to harm the fetus. So for how to test for lead, there are 2 main options. The first one being venous. This is the preferred method from an epidemiologic standpoint because it's much more reliable. It can't be contaminated as easily as a capillary test. And we should be trying to use venous tests for excessively elevated levels, especially those that are 45 micrograms per deciliter or higher, just for that added efficacy. The second option is capillary testing, and this does include filtered paper and point-of-care devices known as lead care devices. This is the most frequently used option. Right now in Kentucky, about 72% of all lead tests are capillary, and the remaining are venous, and then about 1% are not reported as the source was not reported. So I understand, and we always understand that it's a lot easier to get a capillary test on a small child. It's gonna make mom dislike what you're doing a little less, and it's just easier. So really, I just want to emphasize doing venous testing on elevated ones just to get that added efficacy. So included with capillary test is lead care. I kind of categorize it as a third option because you can analyze the results differently. And these are point-of-care devices that allow you to analyze a lead test on site before a patient leaves the building. So you don't have to send it off and wait a week for a lab to analyze it and send the results back to you. These are kind of comparable to a glucose meter in that you can stick a finger and get an instant result. The process is a little bit different, but the company who makes them, Magellan, their slogan is let them know before you go. It's a really useful tool to have in your clinic and do a test right there and know if it's elevated, and you can immediately take the next steps. Currently, about 40 to 45% of Kentucky's lead tests are completed through these devices. So these lead care devices greatly contribute to overall surveillance, but they also have some tricky aspects as well. And I want to address some of these kind of restrictions, the pros and cons, in case your facility currently uses one. Maybe your director comes to you one day and says, hey, I heard about this device. What do you know about it? Maybe we could use it. Maybe you get an elevated result from a facility that uses one, and you just need to understand what it is exactly. So some of the restrictions include the lack of venous testing. We can't use the devices to analyze venous specimens. There was a recall in May of 2017 because the container, the vial that held venous specimens from the company, the inside lid was contaminated with lead. So it caused all of the venous tests for a pretty significant time period to be artificially elevated. I do not know if venous testing will come back for these devices at some point. We really have no information on that. So you can only do capillary tests, and per the manufacturer's instructions, you cannot confirm any elevated levels 5 micrograms per deciliter or higher on these devices. So if you have one of them, you still have to have a contract with an outside lab like LabCorp, Mayo, MedTox, ARUP, Quest, to confirm those results, or you can have a protocol in place to refer patients to a different facility, a local hospital, where they can draw a venous or another capillary that's analyzed by a commercial lab to confirm an elevated. Your facility will need to obtain a CLIA waivership through the Office of Inspector General, and your facility will be completely responsible for reporting these results to the cabinet. When you use an outside lab, a commercial lab like Quest, they handle the reporting burden for you. So they report directly to me, all of the lab tests they do for Kentucky residents. If you use an in-house device, there is no commercial lab to take over that reporting. So it will be completely on your facility to report those. That can become a burden. I have had a number of facilities who have discontinued use of those devices because they just didn't have the staff to keep up with the large volume and getting those reported timely. But if you do use one, the cabinet has made a website and you just go on and report those. We've made it as easy as possible. And if you buy one of these or you already have one, may not be reporting, just get with me and we can get you set up. It's really easy to get those reported. You can have as many users as your facility needs to. So it's not always nurses that report them. Sometimes it's admin or clerks that help too. So each lab will have their own specifications on what kinds of tests they can analyze, how you get materials, how you communicate with them, how they intend to pick up specimens to analyze, and various other issues that they deal with. And you have to be familiar with your lab. I can't always help when I have questions about a specific lab, what kinds of tests they do or what their procedures are, because my relationship with them is very different. It's data driven so that they give me their reports. The best way to do a lead test correctly through your lab is to have familiarity of what your lab expects and their restrictions. If you are thinking of changing a lab or setting up a new lab for lead testing, feel free to get with me and I can search our data and find another health department that uses that lab and connect the two of you, and you all can answer questions for each other and figure that out. I just can't always help directly, but I can always find someone who can help you. So how to prepare for a lead test. This is a somewhat common issue with capillary tests, and this does again include lead care and filter paper. Is an improperly cleaned hand. And this usually means the finger was just cleaned with an alcohol prep pad, which is not enough cleaning to get rid of any residual lead that might be on the child's finger. A piece of lead, 1/10 the size of a grain of salt, left on a child's finger is enough to contaminate 3 milliliters of blood by 1 microgram per deciliter. And that's the unit we measure these elevations. An elevation is 5 micrograms per deciliter or higher. So just a little bit of residual leftover lead on their finger is enough to create an artificially elevated result. And that's why hand washing is especially important for these children who are getting capillary tests. Washing their hand properly will remove excess lead from their skin that will contaminate these specimens. And whenever possible, it's ideal to have a nurse wash the child's hand. We can't trust that the parents understand why we're washing their hand and how, not forceful, but we have to be kind of aggressive to get all of that off. Parents aren't going to wash their child's hand that way. And we certainly can't trust a 2 or 3-year-old to wash their hand like that either. So be sure to scrub their hand with soap and warm water. The warm water doesn't do anything to remove excess lead, but it will warm the child's hand up and help you get enough blood for the specimen. CDC recommends discarding the first drop of blood in case it is contaminated, and then using the remaining drops that you can get for the specimen. And then you have to try to avoid letting the child touch surfaces after you've cleaned their hand, because that could just recontaminate it all over again. So in this section, I'm going to go over what it means to have a confirmatory test for an elevated. So a confirmatory test is required for any elevated blood level that's 5 micrograms per deciliter or higher for children who are younger than 6 years of age. This requirement is in place just to assure accuracy of our capillary tests. Confirming an elevated is especially important in Kentucky because our reference level is low. It's 5 micrograms per deciliter, and that's on CDC recommendations. But this lowered reference level means it is much easier to get a contaminated specimen for a capillary result. A confirmatory can either be a second capillary within 12 weeks of the first elevated result, or it can be one venous, or it can be a capillary followed by a venous within 12 weeks. Some of you might remember from the last CCSG update and the training or the talk I did as part of that, the big change for this year was clarifying that 12-week time frame. This is more of an epidemiologic definition when I'm looking at what levels were confirmed and what were not. This does not mean to wait 12 weeks to confirm. That only prolongs exposure. And I'm really happy to say that since we did that clarification in the CCSG, I haven't seen any more of those that have where the health department has waited 3 months, 12 weeks to confirm. Because when that does happen, the level tends to go up, and then it just keeps climbing because we knew about an exposure, and instead of intervening, we waited. So that doesn't really happen anymore, but I still wanted to mention it because new nurses, they might not understand it. Information gets passed down and can be misunderstood too. And because it highlights why it's very, very important that your cases get sent to me, because I review every single one of them. I review all of your notes, and I track a few variables from there, and I find issues. If you're confused, if you make a mistake, you're not the only one. There are going to be other nurses who are the same way. So please remember to fax your cases, not when they're closed, when they first get opened, to me. And if you need my contact details, I'm in Global. I think I've emailed with most of your nurse managers. So someone in your facility will have my email. So the next few slides are examples, different scenarios of what can and cannot be considered a confirmed test. So the first one is a 2-year-old child gets a capillary test on January 1, 2018. The level is 10 micrograms per deciliter. The child had a capillary test in January 2017, and that one was 7 micrograms per deciliter. No other tests were performed. So is this one considered elevated? And it really is not, because there should have been more tests. In 2017, there should have been another test. In 2018, we would need to do another test to confirm that, since they were both capillary. A 1-year-old child has a capillary test January 1, 2018, that was 6 micrograms per deciliter. The child has another capillary test 1 week later that was 3. This one was properly confirmed, but it was not elevated. So they confirmed it within the time frame, but it's not considered elevated, so no additional interventions or testing needs to be done for this child. And the last one is a 1-year-old child has a venous lead test at their 1-year checkup, and the result is 12 micrograms per deciliter. No other tests were performed. So this one is considered confirmed, and it is elevated. So no other tests need to be done to confirm that one, since it was venous. So for this section, I want to talk about active lead cases and what should be taking place, broken down by ranges of elevations. The first one is results that are under 5 micrograms per deciliter. These are not considered elevated, and therefore you do not need to do a home visit or initiate an active lead case or any other interventions. For these, we really just want to try and ensure that the family has received some form of anticipatory guidance or education about lead. An easy way to address this is if a patient is in your facility getting a lead test. When you administer the test, provide some brief information, a handout, a brochure, a booklet about lead, whether or not it's elevated or not. I understand this is not always possible, since, as I mentioned before, only 7% of lead tests occur in health departments across the state. But when you get mothers, guardians in there who are getting their child lead tested, regardless of the result, try to provide some sort of education to them. If a child has a result that's below 5, they still need to be tested annually based on their on the parent's responses to the verbal risk assessment. Just because they don't have a current lead exposure doesn't mean they won't in 6 months or a year. Families move, things change, dad might get a new job, it could all change. So we still need to go back to the annual testing based on verbal risk assessment responses. So the next one is levels that are between 5 and 14. These are considered elevated, and these cases should receive comprehensive lead education, which covers what lead is and how it is harmful to the body. They should also get referrals to WIC and medical nutrition therapy, and this is to assure the child's diet changes to help decrease the amount of lead stored in their bodies. A home visit should take place within 30 days of an elevation being confirmed. When possible, in doing these home visits, it's best to try and bring a certified risk assessor because they understand lead the best. It is not required to bring them. It is perfectly okay to have the lead nurse go on her own and do the home visit. But these are kind of investigations, and it helps to have a second pair of eyes on site. I've had some where a health department didn't have a certified risk assessor, which is the norm. We have right under 30 certified risk assessors right now. We're working on adding some to that. But in one case, we had a nurse who was new to lead, and she was very overwhelmed. So we tracked down another nurse who had previously done lead in their district and accompanied her, and it went really well. They didn't necessarily need an environmentalist, but it did help to have somebody else there with them, supporting them and helping educate the family. So after this has been, these levels have been confirmed and you've gone through all the various interventions and education, follow-up testing occurs at 12-week intervals. So the last level is ones that are 15 micrograms per deciliter and higher. These are also considered elevated, and all of the previous education and interventions for the 5 to 14 still needs to take place, but there are some additional ones. For referrals, we still need to do WIC and medical nutrition therapy, but we also need to refer for a certified risk assessment and then medical evaluation for a lead specialist, since these are considered more concerning levels. A home visit needs to take place within 1 week instead of 30 days of that confirmatory test. And most health departments tend to do the home visit and the certified risk assessment on the same day to make it easier for the family and the health department. And then for these, follow-up testing should occur more frequently, and it's 4 to 8 weeks. And sometimes in these cases, when they're especially high, the child's primary doctor will test more frequently, which is completely fine. Just be aware you might not see the same decrease if a child is being tested every 4 weeks or every 3 weeks or whatever the doctor decides. If it's not spread out, you're not going to see that decrease in the same way you normally would. So for referring children to lead specialists, these are the two main ones that I've been able to find. So Dr. Nick Newman at the Cincinnati Children's Hospital Lead Clinic, and then in Louisville, Pediatric Cancer and Blood Disorders. I am working to find some additional ones for our more southern and western counties, because we have had issues where family has a very elevated lead level in a child and they can't go, they can't make it that far, they don't have a car, they have to work, they can't take off, whatever the reason. So once I find some more lead specialists, I will be sure to update everyone, because we just can't expect these patients to drive that far, but we still need them to find reliable care when they have those incredibly elevated levels. So as I mentioned, follow-up testing is broken down into 2 categories depending on the level. For 5 to 14 micrograms per deciliter, this should occur every 12 weeks. For higher ones, 15 and higher, we need to do 4 to 8 weeks. So in this section, we'll discuss what it takes to close a lead case and the various ways you can close a lead case. So with cases where the level stayed below 15 micrograms per deciliter the entire case, all you need is one test that's below 5. This could be one papillary or venous, it does not matter. After it's closed, you can go back to annual testing based on verbal risk assessment responses, assuming the child is still under 6 years of age. For levels that are 15 micrograms per deciliter or higher, let me rephrase that. For cases that did exceed 15 micrograms per deciliter or higher, you need to assure the child's blood level stays below 5 micrograms per deciliter for 6 months. So this is not just one test. This can be 2 or 3. Those seem to be the norm. It can be more. It's kind of at your discretion in that regard. If it's an especially elevated one and you've finally gotten it below 5, you are free to keep following it for a little longer just to assure it stays down, especially if it's an occupational exposure. Those stay open very, very long, and it can be very easy for the parent to get lax in their care about bringing lead dust into the home. So another way a case gets closed is if the child ages out. So if a child turns 6 years of age while their lead case is still active, the health department is not required to follow them any longer. In these cases, you can connect with the child's primary doctor to assure they receive continued follow-up care, and you can refer them to a lead specialist if you feel there's some extenuating circumstance that is preventing their level from decreasing normally. Recently, we had a health department that had an active case where the child was, in a few months, they were going to age out, and it had been open for a while, and this child happened to be in foster care. I believe they were in some sort of alternative kinship care, but they had an active DCBS case. So the health department nurse got with me and told me that everything about the case, and the child was in foster care. So I got with DCBS, and we found out who the local DCBS case manager was for this child. So we connected with them and let them know, here's what's going on. It's an elevated case, but we are done. This child aged out of our case management, but we want somebody to know it could still be an issue. And children in foster care tend to be some of the worst about follow-up because I don't know if it doesn't get communicated to the people who are caring for them. Maybe the last home they were in, they had an elevation, and somehow it didn't get communicated to the next home. We don't really know, but in that case, it was a really good idea to let that case manager know so that history will stay with that child wherever they end up, and they can have the care that they need to get that level lowered. So the next one is loss to follow-up, and unfortunately, the lead program doesn't have a lead-specific definition of loss to follow-up. For the time being, we need to use the general CCSG guidance on loss to follow-up. It's kind of an across-the-board loss to follow-up, and it requires a phone call, a U.S. mail letter, and a certified letter. And then if your health department has any specific loss to follow-up guidance or any criteria that you need to meet for that. I've yet to see any health department who follows this definition to a T because it can be quite restrictive to lead cases since the timeline is extended compared to normal care. It can go on for years. Maybe it just goes on for months. Maybe it goes on for 4 years. So that general loss to follow-up definition is pretty weak in terms of lead. Did you have
I was just going to say thank you, Beth, and if I may interject here,
Yeah.
the name of that chapter in the CCSG
Yes.
is follow-up / case management. So it is a standalone chapter in the
Yes.
CCSG.
Awesome. Did I cite it correctly?
You did. You did good.
Okay.
I was just to add that
Yeah,
one
thank you.
extra layer of clarification. There's a standalone chapter in the CCSG
Okay.
that pertains to follow-up. Perfect.
Awesome. Thank you.
Uh-huh.
So for loss to follow-up, if you start running into issues with a family, maybe they've been coming in for follow-up tests perfectly fine, and then they just drop off the map. Their phone's disconnected, their mail, the letters you're sending are getting returned. The primary doctor has a different address, a different phone number, nothing's making sense, you can't find them anymore. Please get with me, and I can do as much as I can. I can look in Medicaid's database, and that has been really successful. If the child is enrolled in Medicaid, they have the address and a phone number. If they have other siblings, mom and dad are usually in there, and I can look at all of those. And sometimes we find an address that's different. Maybe mom updated her address, and for some reason she didn't update the children's address or the phone number. And then going back to DCBS, we've had a few cases where the child has been in some sort of kinship care. They've had an active DCBS case. The health department gets with me. They can't contact the family anymore. They're not responding. I get with DCBS and we figure out who the local case manager is and we rope them in, and the family has a fire under them to get the child tested. I do always make it clear when we do that to the DCBS caseworker, we are not saying anything bad is taking place. This is not medical neglect, assuming it's not. And we just want the child in to get that follow-up care. We don't want to make their issues with DCBS any worse if it doesn't have to be. But if you ever have cases where you can't track someone down all of a sudden, please feel free to get with me. We've done this a number of times with various health departments, and it's been really successful in tracking those people down. It's usually just a misunderstanding of address, or mom didn't update something, or they very rarely are dodging us altogether. So in this last little section, I'm going to go through some frequently asked questions that I get from local health departments. These don't always have a right or a wrong answer, so the best guidance we can offer is common resolutions that other health departments have done. And as I mentioned, you're always welcome to get with me if you have any questions about a case or you're unsure of what to do, even if you've never had a lead case and you're totally overwhelmed and you don't know what to do. You're not the first. Please get with me and I will always help you figure it out. So the first question, this is a very, very common one, and it's, should we do a risk assessment, or when do I have to do a risk assessment? So this is not always a clear-cut case of the child has a level that's 15 micrograms per deciliter or higher. There's usually some extenuating circumstance that causes the health department nurse to have this question. And the certified risk assessments are the one aspect of lead case management that has a lot of legal requirements attached to it. So it's kind of about keeping your health department from causing, issues or getting in trouble for not doing a required risk assessment on a home where a child has an elevation. If your county has a certified risk assessor and you have some sort of question about should or when should I do a risk assessment, get with them first. Most of the time they will have an answer. But like I mentioned, we don't have risk assessors in every county, so you can't always get with one of them. In that case, get with me and we will figure it out. And some of the extenuating circumstances for these cases include the family just moved, maybe they moved from another state and they tell you, oh, that house had a lead in it and this new one's fine. We don't need to do all of this. When they say, oh, we just moved, a lot of times that's not, I just moved in here yesterday. Sometimes it's, we just moved in here last year or 6 months ago. So whatever they say is, we just moved, get more information on that because they don't always understand the issue. So 6 months ago could be a short time for them. For lead exposure, it is not a short time. Another one is the house isn't pre-1978. You don't need to come here and do a risk assessment. Our house isn't old. We're fine. That's not always the case. There's a lead exposure there somewhere, and it might not be the house. Maybe dad got a new door that he found on Craigslist. It was an old door, and he refinished it and put it in the living room. We've had those happen, and it caused a really big exposure. Or they've had some sort of decorative wood in the house that they've refurbished and brought in. It's not a pre-1978 house, but they still introduced a lead exposure.
Or daycare, or grandma's house.
Yes, or they've had multiple residences. So it takes a little bit of investigating, but the answers the families give you aren't going to have the benefit of understanding lead. So we always have to investigate a little bit more. And then another instance where we have this type of question is the family already had an elevation and you did a home visit because it was under 15, and then maybe it spiked over 15. That still requires a risk assessment because something is not being controlled. Maybe we missed something. So there's a lot of, this is not all of them, there are a lot of instances where someone calls and says, I don't know if I should do a risk assessment. It's okay to have those questions and come to me, and most of the time I go to environmental lead so that we don't have any issues with those legal requirements. So the second one is, what if a child's doctor wants to stop testing before we've met closure requirements? This is a really challenging situation that has the potential to erode a parent's confidence in the local health department or even in their own doctor. Essentially, in these cases, all we can do is advocate for proper follow-up testing and hope that the doctor takes our recommendations or understands why we're doing this. Some other health departments have personally connected with the doctor, explained RCCSG, and kind of the why we do this, because these are our primary pediatric providers. They're not lead specialists. It's okay to assume they don't understand lead inside and out. If you ever have a doctor who is being particularly stubborn about this, feel free to get with me and I will gladly connect to them and try to persuade them and sweet talk them into doing this, which I have had to do. Don't feel like you're pushing your job off onto me. I deal with lead 100% of my day. So I am completely comfortable calling a doctor and saying, look, here's what we have to do for this child and here's why. There's also going to be situations where normal follow-up testing isn't really needed. If the child has a foreign body, maybe a bullet or some sort of shrapnel in their body, which are somewhat common. We do have a few of those right now. That foreign body is can be what is contributing to their elevated lead level. We have had some of those where the doctor treating the child said, we're just going to test annually. It's too dangerous to remove this foreign body. There's nothing we can do. There's nothing for the health department to do. We gave them all the education. Their doctor is working with them. And we can't expect them to come in every 12 weeks. We know the source. We know why it's high. There's nothing else we can do. So there are going to be cases like that. But again, feel free to get with me and we can discuss the details and figure out what is the best option for the family in these cases. So this other one is, what if a parent is combative and stops getting their child tested before case closure? So it's not the doctor being stubborn, it's the parent. This happens surprisingly often, and sometimes it's the parents are sick of it. They're sick of bringing their kid in every 12 weeks or 4 weeks or 8 weeks. They lost faith in the health department for some other reason. They're particularly stubborn. They're just over it. Who knows? We've had cases where the family are medical doctors and they're done getting their child tested for lead. They're sick of it. So handling these is really at the discretion of the health department in a lot of ways. If you feel something is going on that constitutes medical neglect, you are responsible for reporting that to the proper parties. Sometimes it's just a hard-headed parent, or the parent is underinformed and scared and they don't know what to do. Some things other health departments have done, they've had another nurse connect with the family and try to build that relationship back up. Health departments involve the child's local doctor, their pediatric provider, because the family might have more trust in that doctor opposed to the health department if they have a long-standing relationship with that doctor. They might trust their recommendation over yours just because of that relationship. Something I noticed a lot recently is we've kind of won families over by offering referrals to other services the health department offers. So WIC is a common one. We had a case recently where the mother was very hostile, didn't want anything to do with the health department coming to the home and investigating the lead source. And the nurse was able to coax her into letting her come and connecting with her. And that same day, she convinced the mom to bring all of her kids to the health department and get the rest of the kids tested, because we didn't know there were other kids in the house. And they got her enrolled in WIC. And so she got something out of that. That happens a lot. And sometimes they're there for WIC and they get referred to get a lead test, or they have a lead elevation. Hey, what about WIC? What can we sign you up for this? That seems to help bridge that barrier where the mom is just feeling guilty and miserable and doesn't like the health department. So that's always something to keep in mind. What other services can we offer this family to gain their trust? So I kind of mentioned this one already. What if you can't get in contact with the family? Please get with me and I can exhaust my resources. Usually we find some other way to contact them or some sort of confirmation that they have moved out of state. We can look in Medicaid database, we can get with DCBS. We have various routes we can track them down. And it's always been successful, except for a few cases where parents have moved out of state and we just didn't know. So always please get with me and we can figure that out. So what if a level increases, or maybe the case was, it was an active case, it closed, and then the level was elevated again? This is somewhat common, and health departments don't always know how to handle that. There are various ways you can handle it, and that one of those can be referring the child to a lead specialist if there's maybe some metabolic issues going on you just don't know. You can always refer them, and if they can get up there maybe to Cincinnati Children's and see Dr. Newman, he can help with that. You can always collect a venous sample if you're unsure of the efficacy of the capillary. Maybe it increased and it was a capillary test and you don't trust that result. Just get a venous and confirm it. And you can always do another home visit. Maybe mom has gotten lax about cleaning the lead dust the dad was tracking in from the battery plant. We don't really know. You don't have to do another home visit, but sometimes it can really help to reestablish the cleaning methods and the education that the family needs to know about. Okay, and that's it for me. I don't know if there's a medium for questions.
There is.
Okay, I forgot to put my email on this last slide, but I am in Global, and you can probably find someone at your health department who's emailed me. Oh, is there? Is just being an environmentalist enough, or is there a specific training to become certified? That's a great question. There is a specific training. It's a 5-day training. It costs about $1,000. And then the environmentalist has to take a certification through environmental lead here at the cabinet. So they have to come up here and do a certification. So on that, I have gotten some additional grant funds to pay for 15 new environmentalist trainings. So if your county doesn't have an environmentalist, then please get with me. I've emailed a few, and we've gotten one trained so far, but you can get with me, and maybe we can use some of that money for your county.
And if they have questions from the environmentalist perspective, Bethlen, who is your point of contact?
Oh, in environmental lead, Amber Agee is the contact down there. But if it's an environmental question and you come to me, I usually check with her just so that I don't say anything incorrect. Can I say one more thing? Okay.
You used to have 4.5 more
Oh,
minutes.
okay, awesome. Perfect. We have some trainings. There's about 10 trainings that we're doing starting in spring 2019, and it's going to be in conjunction with environmental lead, and they are going to be very, very comprehensive trainings. They're going to cover the clinical aspect and the environmental aspect. And I really recommend nurses who don't have certified risk assessors in their county consider coming to those so that you can be armed with that environmental information as well. And I'll have more information in the coming months. We haven't got all of it sorted and where we're going to do them and the dates and everything, but you will be hearing more about that. And then I have some more educational materials that are more updated and current and a little easier to understand than some previous ones that will be coming in the next few months. I will be mailing a small quantity of those to all the health departments, and then you can request more if you like them for your facility. So that's it. And if you have questions, please find me in Global and email me. I will more than happily answer everything I can.
And I've got a question for you, Bethlen. So today's presentation was approved for nursing continuing education, and everyone had the PowerPoint presentation is posted on Train, linked to today's session. So they'll have the PowerPoint presentation and they'll have the audio presentation. This will be available via archive webcast for later viewing. So that might be for if a local health department has a new nurse who would be taking on wearing that new hat of lead nurse for their local health department. Certainly, they could use your PowerPoint.
Yes.
They could go back and view this archive webcast under the train number that we'll send out. They can watch this. They can also obtain a CE certificate for 1.0 CE credits for watching this. So that would be a good training resource that you can offer to local health departments if they weren't able to, if a nurse for whatever reason wasn't able to watch today's broadcast live. He or she could certainly watch this, or an environmentalist could watch this presentation. So that'll always be in archive status along with your PowerPoint, and the nursing CEs will be available for a year. And so that can be a training resource for those who, may.
I have some more trainings in the works,
Great.
so that'll be more comprehensive and broken down
Right.
into various, so it's not overwhelming. It's
Yeah.
different areas for lead.
Great.
So, but this one will be great for now. We'll have that.
Yes, yeah.
Thank you. I didn't know that.
Yeah.
All right. Thank you.
Thank you, Bethlen. Okay, thank you, Bethlen. Great job. Next, we'll go ahead and ask Silvera Marata to come up. And it's a new day. It's a great day in the world of KWCSP. The Centers for Disease Control and Prevention have relinquished and listened to the states over the last many years to cut back on the number of data elements that are required for the Kentucky Women's Cancer Screening Program. Let's see here, I'm going to help. There you go. Thanks, Jamie. And so we're so excited to bring this information to you all, and we hope that you will find it user-friendly. It will be less of a burden for you all, both from the clinical perspective and the administrative perspective, less burdensome for you all as far as collecting data. The form is user-friendly and streamlined, and the team has worked so hard developing both PowerPoint and the new form to get things just right. It's still in its final draft version. We're in the process of, we vetted it through the Nurse Executive Committee. We wanted to share it with you all today, certainly. And then we have asked for a spot on the agenda for next week's CADA meeting to share this updated form with the local health department directors. So we have worked on this, like I said, well, not me, the KWCSP team has worked on that. And I think they've done a really good job. And we've appreciated everybody's feedback thus far. And so if you do have comments after today's presentation, please feel free to submit those comments to Ellen, Rom, or Colleen, or Emily, and let us know if you have suggestions. We want this to, this is your all's form. We want it to be the most readily available and user-friendly and appropriate for you all, while still being able to collect the data that we're required to do so for the CDC, who is our funding agency for this program. So with that, I'll go ahead and turn it over to Ram Silvera Marata, the epidemiologist and the data manager for the Kentucky Women's Cancer Screening Program. So Ram, thank you for being here with us today. There's your PowerPoint. Jamie's got that all pulled up for you, okay?
Remove this one, these buttons. Okay, got it. Thank you very much, Joy. I'm Silvera Marata. I go by Ram. I'm a data manager, epidemiologist with the Kentucky Women's Cancer Screening Program. Very excited to be here and want to share some very good news. As Joy said, it's a new day, and we heard your concerns about the burden of challenges in data collection, and we shared those concerns with CDC. And we have the great news is that the current ACH 58 form we have streamlined, we have cut down the complexity of data collection process. And what I would do is go through those data elements and the options that we have that are available to collect on the data form. And again, as Joy said, this is a draft, And we look forward for your feedback, suggestions, and comments to make it more user-friendly and more acceptable. Again, as this is your form, and we strongly encourage you to reach us out if you can help us with any way possible. So once again, I'm Sivaram Maratha. I go by Ram. I'm a data manager, epidemiologist, and my contact information is here. And going on to the next slide. Before we go on to slides, again, I want to say I would like to thank all the team members, Ellen, Colleen, Emily, Joy, Cindy, Gina, Holly, everyone for designing this form. If you look at, you should all have the form, data form available. If you look at this form, it's much prettier than the ACH 58 form. This has more woman's touch. And it has all the colors in it. So so always look forward for your comments and suggestions. Okay, and I would like to acknowledge Nurse Executive Leadership for your suggestions, for your comments, and helping us design this form and make it more user-friendly. Again, it's very important that you have this form with you as we go through the presentation, because we are going to look at the variables that are on the data collection form, and also look at the PowerPoint. Okay, sorry, go ahead. So data collection form, and the agenda for this today's presentation is to go over the MDEs, which is MDE stands for minimum data elements, and the changes that we are making onto this ACH 58 form. And then, so again, always keep the data collection form and WH58 form by your side so that we can look at all those variables. The purpose of collecting the MDEs or minimum data elements. So one is what we do. What happens is that when we collect the data from you, we take the data, polish it, clean it up, look for inconsistencies and completeness, and we polish the data and then send it to CDC. The CDC then looks at the data and does more detailed analysis with the data. They would look at several aspects, looking at the quality of care that's being offered, and then the justification of funds, and then also look for the timeliness and completeness and accuracy of the services. So the data that we collect or you provide us is very important, because they are very critical decisions. The program decisions are made based on the data. So we always request you to provide us, a timely, complete, and accurate data to us. And if you have any questions on data collection process, any of those options or variables, please let us know. And also the requirements from the CDC grant, which is around $2.5 million, which we get from CDC. The requirement is that we provide this data, the MD data that we collect on the ACH or the 58 or WH58 form, is a receipt for the federal funds. So we have to kind of provide a very high quality of data, and we have to provide them twice, semi-annually. One is on April 15, the second one is October 15, and that is why you see during March and September, the calls we make to health departments are usually kind of very high during those times, because we are looking for any kind of accuracies or confirmation of certain data elements, or looking to complete the pending records. And I want to thank you all for the last MDE submission. I want to say we met all the quality of care indicators, and we have been meeting this quality of care indicators for last 18 years. We have not missed any of those quality of care indicators. We have done, and the reason we met all the quality of care indicators is that you have provided an excellent quality of care to the patients. Far excellent quality of care, and we are among the very few programs at the national level to provide such an excellent quality of care, and we never missed our quality of care performance indicators. So once again, thank you and congratulate you on meeting all the quality of care indicators. So the data for the quality of care indicators, again, it comes from the WH58 or ACH 58 form. Okay. KWCSP eligibility. Eligibility did not change. It's still age 21 to 64 years of age, uninsured, no third-party payers, no Medicare, no Medicaid, no private health insurance. Household income should be at or below 250% of annual federal poverty guidelines. One thing that has changed during last 3 years is the family planning, PAPS. Cancer screening program is paying for the PAPs done through the family planning program for women eligible for KWCSP. So what it means is that we will need an ACH or ACH 58 form or WH 58 form to be completed all women who had PAP test done through family planning program and are eligible for KWCSP. You should have a pop-up coming up on the screen as soon as the family planning patient meets a criteria guideline, the eligibility guidelines, saying that you got to fill out ACH 58 form or WH 58 form on those family planning PAPs. And if you do not get those pop-ups, please let me know, or Gary Causey at CDP know about not receiving those pop-ups or reminders that you're not being reminded, or a label C has been not generated for family planning patients who have PAPs and who are KWCSP eligible. Okay. I think this is the MD data collection form. This is a big change, even when it was hard on me. So ACH 58 form is now called WH 58. So ACH, the reason for the change in the name is ACH stood for Adult and Child Health. Back in 2003, 2004, the cancer screening program was housed in the Adult and Child Health Division. So it was named after the ACH, the data collection form was named after the division ACH 58. So now we would like to kind of reflect it in the women's health. So now it is women's health WH 58 form. The implementation date, we plan to implement on January 1st, effective January 1st, 2019. Coming to the data collection form WH58 form, this is we can find more simplified. There are less number of variables in the current ACH 58 form. We had 62 variables, and now we have it's been down to less than half, which is around 36 variables being collected on the form. It's less complex, it's more simplified, and one of the complex part of the current ACH 58 form was the diagnostic procedures for both breast as well as cervical, like via ultrasound, the diagnostic mammograms, and biopsies or colposcopies. The entire section is being taken off, removed. So we don't have the complexity part. So it's now more simplified, more easy to collect than in the past. The data collection form has two major columns. One is the breast column, the other one is the cervical column. The breast column has again 3 subsections, and cervical column has 3 subsections, A, B, and C. Section A and Section B are more related to the screening part, and whereas Section C is more related to the diagnostic part. So what I would do is go over the sections both in the breast and cervical columns and provide you, kind of share with you the options that are available. Again, this is a draft, and we are looking forward for your comments or feedbacks to make it more user-friendly and more supportive. The first element in the breast column is the breast services provided. We have got this is a new data element. We have 2 options. One is yes, and the second one is a no. Check yes if a woman has a CBE, she has a mammogram done, or she has a diagnostic mammogram or an MRI or any of the diagnostic procedures. If she has one of those procedures, then this should be marked as a yes. If she does not have any of these services, then please mark as a no. And if you mark as a no, then please proceed to the cervical section. You don't have to fill out the breast cancer data if you mark it as a no, but if you mark it as a yes, then you will have to fill out the screening part and a screening part of the section. The next element in the section A is the first element in section A in the breast screening data is a CBE. This is the older data element. And we have got 3 options. One is a normal, abnormal, and CBE not performed. If it is a normal or abnormal, we need a CBE date. Again, this is an old element which is on the current data collection form. The next data element is a mammogram. If you see on the PowerPoint, you will see some of the variable names are highlighted in the pink, which means those are data elements that are collected on the Women's Health 58 form, WH58 form. So that's how you can identify them, that these are the variables compared to the notes and options available. So mammogram has 4 options. The first one is a routine mammogram. The second one is for diagnostic mammogram is ordered. And the third one is the mammogram is done elsewhere outside of the local health department. This is where mammogram has been done. A woman found out she had an abnormal mammogram, and she comes to a health department for further diagnostic testing. This option number 3, is very rare to happen. It's very rare. It's not frequent. Option number 1 is more frequent. Option number 2 is less frequent. But option number 3 is very, very rare and very frequent. Very, very rare. And if she has a mammogram done elsewhere, we request you to provide the date referred to the local health departments. Again, if a woman does not have a mammogram done because she has not kept her appointment or she does not need a mammogram, please mark it as a mammogram not performed. The next continuation on the same mammogram, date referred to local health departments. This is one of the questions I get frequently from health departments. So what date do we put in? It can be the date where it can be the date the woman has contacted the local health department. It can be the date of the procedure where you have sent the patient for the diagnostic testing. Any of those dates can qualify as a date referred to local health department. There's no exact date. We can put in any of those approximate dates, where usually what I recommend would be the day she had the procedure done would be the date of refer to local health departments. MRI. This is a new variable on the WH58 form. We have 2 options, yes and no. But please remember, this is a screening MRI. This is not a diagnostic MRI. If MRI is done as a part of screening, then you will check it as a no. If an MRI is done as a part of the diagnostics, you will check as a no, because what we are looking for here is a screening MRI. So I would like to make a distinction clear on this. If MRI is done, please screening MRI if MRI is done for screening purposes, then you will report as a 1. Okay, this is a new data element on the WH58 form. Is a client at high risk for breast cancer. There are 3 options. We got yes, we got no, and we got unknown. If you see there's an asterisk before this data element, what it indicates is that if you turn on the back of the WH58 form, there's a further guidance available to you all, and what the more clarity, more definitions of yes, what can qualify as yes, what can qualify as a no or unknowns, that is available on the back of the WH58 form. Please take time to go over those risk factors and before you mark yes, no, or unknown. Mammogram MRI results data. Again, this is an old data element. We have not changed. The results, the barriers have not changed, both for mammogram, the barriers for the mammograms, MRIs, and ultrasounds or diagnostic mammograms have not changed. They still stand the same. So we still have the same options from 0 to 6. If a woman has had a mammogram done, so we request you to enter the MAM date. Again, as asterisks indicated, you will find the BIRADS codes on the back of the WH58 form. Section B, MRI results data is the same thing, same BIRADS, just like we had for mammograms. We have the same BIRAD results, 0, 1, 2, 3, 4, 5, and 6. If a woman had a screening MRI, so please mark this one of those BIRADS codes and then also enter the MRI date. Diagnostic section B, going to the last data elements on section B, diagnostic procedures or workup plan. This is the older data element. We have got 2 options. One is yes, second one is a no. This data element is a transition between the screening section and the diagnostic section. So we have two options, as I said, yes or no. If a CBE, a mammogram, or MRI is abnormal, and then the diagnostic workup should be planned as a 1, and otherwise, please report as a 2. Based on the data for last 10, 15 years, I would say 95 to 98% of the time, you will report diagnostic workup planned as a no. There are probably just 2 to 5% of the cases, or 2 to 3% of the cases reported will have diagnostic workup as a yes. If you mark diagnostic workup, you must mark diagnostic workup as a yes or no to close the sheet. If you mark diagnostic workup procedures as a yes, then please complete the section C of the breast column. Okay, which I would go. Okay. So if you see, this is section C. The same 5 data elements that we had in the past, or we have in the current ACH 58 form, is the same old 5 data elements. If you mark diagnostic workup procedures planned as a yes, then you must complete the section 3, 1, 2, and 3, which is the status of breast diagnosis, data final diagnosis, and final breast diagnosis. If the final breast diagnosis is invasive cancer or a pre-cancer, then data elements, treatment status, and treatment date should be completed. Otherwise, they should be left blank. So I will kind of go over those data elements with you. But if you mark, once again, if you mark diagnostic workup planned as a yes, then section C must be completed. The first element in section C is the status of breast diagnosis. We've got 3 options: workup complete, loss to follow-up, and workup refused. The current ACH 58 form has workup pending. We took that option off, so it's no longer kind of relevant because what we found out is that the data form is still kept open if the woman is going through the diagnostic workup. So we have these 3 options: workup complete, loss to follow-up, or workup refused. If you mark diagnostic workup planned as a yes, the status of breast diagnosis must be completed. You must mark it as complete, loss to follow-up, or workup refused. Loss to follow-up. One of the questions I frequently receive is that what is a loss to follow-up? How do you define loss to follow-up and differentiate with the workup refused? Loss to follow-up is used when the tracking efforts have been attempted but have failed. You cannot look at a woman has moved and you don't know where she is. You made all the attempts to contact the patient, but you could not. In those cases, you report as a loss to follow-up. Workup refused is when you can contact the patient, but a patient refused to keep an appointment. It can be for diagnostic mammogram, it can be for surgical consultation, it can be any of the procedures. The woman fails to keep an appointment or refuses to keep an appointment, then you must report as a workup refuse. CDC gives us a certain percentage where we can report a loss to follow-up on workup refused cases. So they want us to make all the attempts possible to reach out to this patient to see the final diagnosis is that we have met all the, this is a very important quality of care indicator variable, and we met all the quality of care indicators because you have done an excellent job in reaching out to these patients above and beyond what is required and what is. So I want to thank you very much on this. I know several times you called on the patients, you went to their homes, and the patient has moved to a different private provider. You reached out to them, to the providers, to get all the information we need. So thank you very much for reaching out to these patients and also for completing this data element. Data final diagnosis. So again, going back, if you report as workup complete, loss to follow-up, or workup refused, you must complete the data final diagnosis. Final breast diagnosis must be completed, which can be, this is again all the data element. We have got 4 options: ductal carcinoma, invasive cancer, breast cancer not diagnosed, lobular carcinoma in situ. Based on the data, what I can say is pretty much most 98% of the cases who have diagnosed workup as a plan report as breast cancer not diagnosed. We have a very small number of cases reported as a ductal carcinoma or invasive breast cancers. If you report the final breast diagnosis as a ductal carcinoma or invasive breast cancer, then treatment status and treatment date must be completed. If you report final breast diagnosis as breast cancer not diagnosed, then you don't have to complete treatment status and treatment date. They have to be left blank. One of the questions and the challenges we have here in data collection is that health department staff have reported breast cancer not diagnosed and still have entered treatment status and treatment date. Treatment status was reported as treatment not needed. It makes sense. Woman does not need a treatment because she did not have a breast cancer, was not diagnosed. But the CDC definition is a treatment not needed is very different from what it's in general practice. Treatment not needed should be used only in those cases where patient and the physician both agree that providing treatment will cause more harm to the patient than benefit. Usually it is in late stage or later end stage cancers. How many cases truly qualify as a treatment not needed? I would probably say maybe 1 or 2 cases at the most in a year where we get treatment not needed as a very genuine option. If not, treatment started or lost to follow-up or treatment refused are more options. So before you report as a treatment not needed, please call us or send us an email saying, Ram, we have a situation where the patient does not want to have a treatment done. So we will check and we'll see how we can report that variable. Because oftentimes, if you report treatment not needed, we have made calls to health departments to you all saying, is this accurate that you have reported treatment not needed? So again, please report treatment status and treatment date if woman if you report the final breast diagnosis at carcinoma or invasive breast cancer or lobular carcinoma in situ. So that ends the breast column. Again, we have got A, B, and C. A is a screening, B is a screening, and C.
I've got a question. There may be other questions from
Yes.
the other room. I don't know. Let's ask if there's. Let's take this opportunity to see if there's questions before we go on to cervical, if you don't mind.
Yes, please.
But I just wanted to remind the nurse leaders that the clinical guidance for using an MRI as a screening tool for high-risk women, that was added to the CCSG in July. And so now the new form, the Women's Health 58 form, reflects that option as offering and providing the MRI for a high-risk woman. So just wanted to be sure, and if you all have questions about that clinical guidance for high-risk women, that's all written out in the CCSG. I just wanted to remind you all about that change from the clinical perspective.
Okay.
So that's why we've added that into this new form. And you do in fact have a question. Looks like I'm gonna say yes. Okay.
Yeah. Question is: are local health departments required to provide cancer screening services for those with Medicaid and private insurance? What we'll do is we'll get back to you on that question.
No, I
Yeah,
can
go
help
ahead,
them with
yes.
that. Yeah. You have anything
Yes,
there?
yes.
Okay. So the question is, I believe our local health departments are required to provide breast and cervical cancer screening services for women who have other payer sources. All local health, including Medicaid and Medicare. All local health departments are Medicaid providers. So if you have, so there is that ability in place for local health departments to bill Medicaid for those services. And I believe most, if not all, local health departments are also Medicare providers. There may be some that are not, but that would be a local decision as to whether or not you all provide services to Medicaid or Medicare beneficiaries. Certainly that is dependent upon your all's capacity at the local level, what your local policies are, and then as far as what your community need is for women to screen women who have Medicaid or Medicare. Certainly with the ACA, the advent of the ACA in 2014, we have a very high coverage rate for Medicaid in our populations, particularly those populations in need that local health departments have always served. But those women now hopefully would have a medical home. And so that would be a conversation for local health departments to have with their, with their nurses and their directors and, other leadership, the boards of health perhaps, other providers in your community to make that determination to assure, at the end of the day, to assure that access to care for those women in need. So KWCSP is a safety net provider. It provides services, breast and cervical cancer screening services, as you are well aware, to those individuals who don't have insurance. So if your all's internal policy is such that you would refer Medicaid clients or Medicare clients to their medical home, that would be a local decision. Okay? Does anybody have any questions about that? Ellen, was there anything you want to add to that? Okay. All right. So end of the day, we want to assure that access to care for the women who need those services. So that community collaboration between the local health department and your community stakeholders, your other providers, healthcare providers, Medicaid providers, Medicare providers, that's the key to success in that regard. Thank you, Ron.
Thank you, Joy. Is there another question?
No, that was only question.
Question about it?
Okay. Yeah. Now we move on to the cervical section. I got cervical section. Cervical column has 3 sections: section A, B, and C. Again, A and B are related to screening services, and section C is related to the diagnostic services. Cervical services provided, just like breast services provided, we've got 2 options. One is a yes, 2 is a no. If a pap test, if a HPV, or any cervical diagnostics like a colposcopy or biopsies are provided, then you will report this, mark this as a 1. If not, you will mark this as a 2. If you report no cervical services as provided, or if you mark it as a 2, which is a no, then you do not have to complete the cervical section. You have to leave this column blank. Section A, prior pap test. This is the old data. We got 2 options. One is a yes, and second is a no. What we want to know is when was the last time woman had a pap test done. And if you mark this as a yes, please enter the date. It does not have to be an exact date. It may be, woman may say, well, I had a pap test 5 years back. You can enter the year and leave the month blank or put a 99 in that one. So this is self-report data. What we're looking for is an approximate date. If you know the exact date, that's fantastic. But if you do not know the exact date, an approximate date will work out. Pap test, this is an old data element. We have 5 options available. One is one for the routine screening. The second one is for short-term follow-up. Again, third one is for if a woman had a pap test done elsewhere outside of the local health department, and she has come to the local health department for colposcopies or maybe further diagnostic testing, then you will mark this as you'll mark this as a 3. If you check this as a 3, if you mark this as a 3, then date referred to local health department must be completed. This is again a very rare. You'll find this is a very rare option. 1 and 2 are more frequent compared to the 3. So just like mammograms. So if a woman had a pap test done elsewhere outside of the health department, then you'll check this as a 3. Option number 4, yes, pap performed after primary HPV. This option will be available to you all after July 2019. Check 5 if a pap is not performed. If woman refuses to have a pap test or she does not have a pap test, please report as a no pap not performed. Continuation on date refer to local health department. Once again, if the pap test was ordered and performed outside of the local health department, then the referral date must be entered. HPV test. This is the old data element, but we have new options in the past. In the ACH58 form, you had yes or a no question, yes or no option. Now we have 3 options. One is a co-testing, the second one is a reflex, and third one is a test not done. Just like with the breast cancer, we have we have a variable. It's a new data element. Is client at high risk for cervical cancer? We have three options: yes, no, and unknown. Again, this is indicated by asterisks. You will have more clarification, more definition at the back of the WH58 form, and what can be defined, what is yes, true, as a no, or unknowns. Pap test test results. If a woman has a Pap test done, please enter one of these results. These are the same old results. There is no change in the codes. We still have 1 to 9 options. If she has a Pap test done, please enter the Pap date.
And Ron, may I interject
Yes.
one more time? I apologize. The HPV test, the clinical guidelines have been revised related to HPV testing as a primary test for cervical cancer, and so we will be incorporating that clinical guidance change into the CCSG in July, and so that's why the form, the new Women's Health 58 form, does reference July 2019 as an upcoming change that will be consistent with clinical protocols, clinical guidelines that will be made in the CCSG. So we made the decision to go ahead, add that clinical data element now, and so the form will be ready and ready to go for July when we change the clinical protocols. But most of your APRNs and many of you all as nurses have probably heard about that change, read about that change that's forthcoming as far as using HPV as a primary test. So just so you'll know, that's incorporated now in anticipation and preparation for the transition to the CCSG change, which will be reflected in July of 2019. Thank you, Ron. Is that okay?
Yes.
Okay.
Thank you. Okay. The next data element is HPV test results. We have in the past we had just only had positive and negative. Now we have more options with the genotyping. So we've got 1, 2, 3, and 4. 9 is unknown. Again, you will find more directions and guidance on this on the options at the back of the WH58 form. What we are looking for is a high risk 16 and 18 types, not the low risk ones. The high risk 16 and 18 need further follow-up based on the CCSG guidelines. So that's one of the reasons why CDC has differentiated, classified the HPV test results into more positive and the positives and negatives, and if it is a positive, based on the genotyping. Okay, this is again a very important data element connecting the screening procedures with the diagnostic procedures. If a Pap test or HPV test results is abnormal and the diagnostic procedures are ordered, then the diagnostic workup must be set to 1. If you mark diagnostic workup as a 1, then section C has to be completed. If you mark diagnostic workup as a 2, you don't have to complete the section C on this on the form. 98% of the cases you will report as a diagnostic workup as a no, where it ends. If you mark it as a yes, then she has a colposcopy, or she has a colposcopy with biopsies, or she has a LEEP or cold knife cones, or she has planned for any of those procedures, then you report or mark it as a 1. If you report diagnostic workup planned as a 1, you must complete section C, which is section 1, 2, and 3. I put in the breast diagnosis, but this is a cervical diagnosis. Okay, section C must be completed. Items 1, 2, and 3: status of cervical diagnosis, date of final diagnosis, and final cervical diagnosis. I know it reads breast diagnosis, but cervical diagnosis have to be completed. Then go later. I'm trying to skip that slide. Okay. Okay. The status of cervical diagnosis. If you mark the diagnostic workup plan as a 1, as a yes, then status of cervical diagnosis must be completed. It must be either you can report as a workup complete, lost to follow-up, or workup refused. The definitions for lost to follow-up and workup refused is exactly the same as for the breast cancer section. If a woman, if you cannot contact the patient, if she has moved or if she has died, you will report this as a loss to follow-up. Workup refused is when she does not keep an appointment for surgical consultation or for colposcopies or any of those diagnostic procedures, then report as a workup refused. Date of final diagnosis, if you report any of these three options, workup complete, loss to follow-up, or workup refused, please complete the date of final diagnosis and the final cervical diagnosis. Well, sorry. If you report loss to follow-up on workup refused, you don't have to report the final cervical diagnosis. But if you report workup is complete, then final date of final diagnosis has to be completed and final cervical diagnosis has to be completed. In this, the options 1 to 6 are pretty much the same. They have not changed, but please complete options 2 and 3 if you report workup is complete. If you report loss to follow-up or workup refused, you do not have to report final cervical diagnosis, but you have to report date of final diagnosis. That usually the date of final diagnosis will be the date when you send a certified letter to the patients. That will be the date of final cervical diagnosis if you report as a lost to follow-up or workup refused. Same thing with the treatment status and date of treatment status. If a woman had a final cervical diagnosis of 4, 5, or a 6, a SIN2, SIN3, or invasive cancer, please complete treatment status and date of treatment. It can be LEAP, it can be cold knife cones, any of those procedures can be reported as a treatment status and treatment date if they're done as a part of the treatment. Again, the cancer screening program will only pay for LEAPs and cold knife cones if they are done as a part of the diagnosis, not as a part of the treatment. If a final cervical diagnosis is a SIN3 or SIN2 and invasive cancer, and the physician wants to go ahead and the patient wants to have a treatment started, please complete the BCCTP application and file BCCTP. The cancer program should not and will not pay for LEAPs and cold knife cones if they're part of the treatment. They will only pay for LEAPs and cold knife cones if they're part of the diagnosis. So this is one of the common questions we get, saying, do you pay for the LEAPs and cold knife cones? Yes, if the patient has been diagnosed or is a LEAP or cold knife cones part of the diagnosis. So if you report 4, 5, and 6, SIN2, SIN3, and invasive cancer, please complete treatment status and treatment date. It can be treatment started, lost to follow-up, treatment refused, or treatment not needed. Again, treatment not needed. Please report treatment not needed only if the physician and the patient both agree that having a treatment done will cause more harm to the patient than benefit. Again, this is a very, very rare situation, a very rare circumstance. I'm looking at probably 1 or 2 cases in a year across the state where there's where this option of treatment not needed is very genuine. So please call us before you report treatment not needed. Women's Health 58, WH58 form, back quick reference page, you'll find a lot of guidance. Both the front and back side of the form have changed. So if you can take a quick scan and look at it, if you have any questions, if you have any comments, or if you have feedback to make the form more user-friendly, please let us know. This is my contact information, but you can reach out to Ellen, Colleen, Gina, Holly, any one of the cancer team with your questions. We always look forward for your feedback, questions, and suggestions.
Do you want to mention the effective date?
Yes, the effective date, again, go back. Oops. Okay, the effective date, I think, go back to the first. We plan to implement the effective date is January 1st, 2019. We would like to have you will have the data screen coming up, a new data screen reflecting the new ACH 58 form, and the forms will be available to you all prior to January 1st, 2019.
So PSRS is going to be modified to mirror the new Women's Health 58 form. So it will be a mirror image of each other.
Yes.
For use and user friendliness to
Yes.
be able to enter that data.
Do you have any questions? Okay.
Thank you, Ram, and we certainly hope that the goal is that local health departments, both the admin staff and nurses who enter data on the Women's Health 58 find that easier. It's less complex, there's less data elements that are, that we will be asking for specifically related to diagnostic
Yes.
results. Is that true?
Yeah.
And so we hope that will streamline the process, kind of remove some of that administrative paperwork
Yes.
burden for our local health department partners.
Yes, and actually, because the current ACHQ platform, Joy, has 62 data elements. Now it's down to 32 data elements. It's a half of what we are collecting. So the challenges that you had with all this data collection process, it's even some of those data, even those the variables that we have, they're less complex. The options are more clear than what we had in the past. Example, for short-term follow-ups were not clearly defined in the past. Now we have got a new option for short-term follow-up. That was one of those very confusing options for the local health department. So we have received several questions on that.
And so I think those are really two good numbers to just to reiterate and go out on a, I'm just thirsty there, sorry you all. Go from 62 data elements to 32 data elements.
Yes.
And so that's a great 50% reduction
Yes.
there. Thank you so much. Thank you for letting me interject into your presentation. Yes, let me show you here. Right here. Uh-huh. Next, I'll invite Emily Anderson and Charlie Ray to come up. Emily, as you all know, is the TB Prevention and Control Program Manager, and so she's going to be providing some information and kind of to get us started on the TB program as it relates to year-end data and reporting. And then I know she'll be introducing the new epidemiologist for the TB program, Charlie Ray. So thank you all so much, both of you all, for being here today. I do want to start out with an apology. As some of y'all may have received a lot of emails from Ron this week, and the email said, this is Joy, this is from Joy. My email account, my whole computer was shut down on Monday due to a phishing email, unfortunately. And so Charlie had sent me an email with several data reports and supporting documentation for today's presentation, and I didn't get that. I was not able to send that out on Monday before my account was shut down. So my apologies to Charlie before he starts his presentation. And I do hope my early Christmas present today is going to be that I get my account back to me, all up and ready to go. So as soon as I get that information, get to my computer, I'll be certain to send that out. So you'll have that available, that information, those reference documents available for your information and your use. So with that, I'll turn it over to Emily, and thank you, Emily, for being here today.
Well, thank you, Joy. I appreciate it. Good morning, everyone. We're excited to be here today. I do want to introduce, as Joy mentioned, our new epidemiologist, Charlie Ray. He joined us July 1st. His name may be familiar to some of you if you've already been having some communication with him, but he also did his internship with the reportable disease section before graduating from the University of Kentucky last year. So we are really excited. He is going to be giving you an update, as Joy said, about year-end data and reporting. And I'm just going to go ahead and turn it over to him.
Sounds good.
You're okay there, Charlie? Need to...
I think we're good. I don't know if it needs to be moved or not. Yeah.
Check that.
Say, you just tell me.
Fix that camera.
This is not new. Don't worry. Yeah.
Charlie's about a foot taller than everybody else is this morning.
You know. Yeah. Problem. Thank you. Okay. All right. right, well, good afternoon. So like Emily said, my name is Charlie Ray. I'm the new epidemiologist with the TB program. So started in July. Don't feel very new anymore, but I may be new to some of you. So before we get into the actual year-end data and reporting requirements, we thought it would be a good idea to actually talk about my duties, especially as it relates to local health departments. So in the future, if you all need anything from me, you know what I'm in charge of. But after that, we're going to get into the year-end data completion. So we're going to talk about getting all of your data into NEDS, making sure you're reporting all of your suspects, and then we will get into the ARPI form, which some of you may be familiar with. Our aggregate report for program evaluation is coming up. That's going to be due in February, and then we're going to talk a little bit about what's coming up in 2019. So first, my duties. For epidemiologists of the TB program, as you might imagine, it is all surveillance related pretty much. So TB NEDS entry, that's probably where I get most of my questions so far. So anything related to the TB investigation in NEDS, I am your guy. ARPI, which we'll talk about here in a second, I'm coordinating all of that. And then also our TB GEM system, which is our genotyping system. So if and when you have genotyping data available, or if there's a cluster investigation that we need to know about, that's all accessed through GEMS, and I take care of that. So those are really the three big things that I deal with surveillance. But a couple of other things that we thought about as it relates to local health department needs. I will also be requesting death certificates from Vital Statistics. So if you have any dead or died patients in TB, we know that we request those every year, so I will be in charge of that. We're working on that right now, actually. You'll be seeing me at TB 101 trainings for all your new nursing staff, and we're also working on rolling that out to new regional epidemiologist staff, so that's exciting. Yes, website editing for all of our TB pages, so any new documents, data, anything that goes on the website, I will be in charge of that, and then just other miscellaneous data needs. So please, anything and everything that you have questions on as it relates to any of those things or just anything else, please let me know, particularly when it comes to surveillance and data. NEDS, like I said, has been the thing I've gotten the most questions on. That's really priority number one for me. I want to make sure that everyone has a lock on that. So if you guys ever have questions or get stuck or just need anything, let me know. Everything gets kind of dropped so that we can help you all with that. That's kind of priority one. Okay, so transitioning now to our year-end reporting. So like Joy talked about, we have been in the process of mailing out the year-end packet. So the year-end packet has been sent out in a hard copy before through the snail mail. That's how we used to do it. So if you've been with us before, you might be expecting an actual packet to come in the mail. We've changed that. It is now an email packet. So we sent that out on Monday, December 10th through our TB coordinator listserv, as well as the local health department director listserv. And then eventually, like Joy said, when she gets back up and running, that'll also go out through her listservs. So it's still in the process, but you may have already received it through one of those other listservs. And if you did, you will know that besides the email, there were 4 attachments to that, and they're listed here. So contents of that, the first one is the year-end letter and memo, and I kind of emphasize that if you're going to read anything thoroughly, please read that thoroughly. It goes through what we need at the TB program from your all's end, as well as the due dates for those. So be sure to check that out first thing. The second one is a reference timeline. It's just a little graphic organizer. We pulled all the info from the letter and the memo and just stuck it in some easy to read tables just for quick reference on what is due and when. The ARPI forms are in there, which we'll talk about, and then some ARPI instructions. So 4 documents are in that email packet. And just to kind of sum it all up, what are we asking you to do? It's 2 things. One is the year-end data completion, so getting everything into NEDS, and then 2 is doing your ARPI forms. So let's get into that. Okay, so first is the year-end data completion. So this is, again, getting everything into NEDS. So if your jurisdiction had a case of TB in 2018, we just need you to complete all the sections of the RVCT in NEDS. So just get all that data in there. What we don't want any missing variables or variables that you can mark unknown. We don't want any of those. So just go ahead and actually fill in all of those pieces. Really, the only variables that can or should be left blank is if they're still on treatment. So if you have a case that is still being treated, of course, those treatment completion variables, which I believe are 43 and 44, you can leave those blank because, of course, you won't have a date for those yet. So just kind of keep an eye on that. But everything else, please be sure to go ahead and get those entered. A couple of things to mention, like I said, no unknown variables. Be sure to hit not done if it's a lab test that they didn't do. Don't put unknown, put not done. That sometimes happens. And then a couple other variables. We know some of our jurisdictions will leave blank. I think it's variable 42 is a moved variable. So if you had a case that moved out of your jurisdiction, you can put information there. A lot of people will leave that blank because they haven't moved, but they might. Go ahead and just put no. Just fill in all those variables, and then if anything changes in the future, we can change it. So just go ahead and get all of those completed and finished out. So that's for your confirmed cases, true TB cases that you all have got. The second piece to that is all of your TB suspects. So you all know this, that when you have a suspected case of TB, that you report it to us. You give us a call or send us an email and let us know that, hey, we've got a suspected case of TB. We're checking it out. We're doing the evaluation. We're trying to determine whether or not it's TB. You all are already doing that. And then second, you are to enter those cases into NEDS. Now, you don't have to complete the whole RVCT. You don't have to go all crazy, but just get their names in there, get the basic rundown information that you have. Basically tell us why it's a suspect is what we need. But complete as much information as you have. So the reason why I'm bringing that up is if you have any TB suspects that you maybe haven't reported to us yet through the year, or that you haven't gotten entered into NEDS, please go ahead and do that as well. So we want both of those things. Finish up RVCTs for completed and confirmed cases, and then any suspect information that you haven't gotten to us, go ahead and let us know about it, and then get them into NEDS. So those are really the two big things. So this is a screenshot of the memo that I have been referring to, and I'm pulling it out to show you that in that first paragraph, it talks about basically everything I just talked about. And I wanted to point out that the due date for all of the data into NEDS and to report suspects to us, if you guys can get that to us by January 14th, that is when we would like it. So we can go ahead and start getting those finalized case counts for 2018 ready to go and submitted to CDC. So that is January 14th is when we need all of that reporting data. Then the ARPI form. Okay, so if you are unfamiliar, ARPI stands for Aggregate Report for Program Evaluation. So this is a data collection tool that we use for our contacts to active TB cases. So if you've not filled one of those out, this is what you're focusing on, is all of those contacts. So there's a screenshot of it. It looks pretty much the same if you've done this before, but you'll notice at the bottom, there's not all those calculations anymore. You all didn't need to do them. We'll do them on our end. So now it's just instructions and reminders. So, but everything else is exactly the same. So just to review, again, you're tallying all of the contacts. And if you go down that bulleted list there, you're seeing that you are just tallying up how many contacts you were evaluated, how many had TB disease, how many had LTBI, and you're just going down that list. And the purpose is we are trying to evaluate our programs at the state level. So you are filling out an ARPI form for your jurisdiction, but at the end of the day, what we submit to CDC is just one giant Kentucky ARPI form. We add everyone's together and we send in one form at the very end. And we're trying to find out where in our contact investigation or our LTBI treatment for contacts we are, and I put in quotes, falling out. So we want to know where can we improve. Are we, what exactly do we need to improve on in terms of contact evaluation or getting people started on LTBI treatment, completed LTBI treatment? We just want to know what's going on in the state. So who needs to fill out the ARPI? This is always kind of the biggest point. So if your jurisdiction had a case in 2017 or 2018, you're going to be filling out ARPI forms this year. So the 2017 final ARPI, that's what we're collecting this year, and then our 2018 preliminary ARPI. So that's why if you had a case in either one of those years, you'll be filling it out. So if you did not have a case in 2017 or 2018, this is a confirmed case, you don't have to fill out the ARPI form. And then sort of vice versa. If you just had a case in 2017 but not 2018, just fill out the 2017 form and not worry about the 2018 and vice versa. So you are going to be filling out a form according to the years that you had a case. So that's who's filling it out. What I also did is on December 10th, after we sent out the initial packet, the year-end packet, I sent a follow-up email directly to you. And these emails were sent out to individuals who had cases in 2017 or 2018. It's just a reminder that since you had a case in one of those years, you need to be filling out the RP form. And what I did in that email, if you saw it, I just detailed the total number of cases that you had just as a double check. I'm telling you, hey, on our end, we're showing this many number of cases. Hopefully that's how many you have as well. So just to kind of double check. And we also detailed in the RP form how many cases need to go into which column, which I'll detail here in just a second. So like I said, here are the two different RP forms. They're exactly the same, but we've gone ahead and pre-filled in the 2017 and the 2018. So just fill out the appropriate form for the appropriate year. And then this is broken down just to highlight a couple of pieces to remind you to fill out. So the first one in that red box, please be sure to enter in all of that contact information. That's going to be who is filling out the RP form, so your email and your phone number. Just in case there's any future questions, we want to be sure to contact the person who actually filled it out. I know some of you all have regional EPIs who help you do this, or local EPIs, certain nursing staff. So we want to make sure that if I have a question, I call the person who actually filled it out, who can help us out. You'll see in this green circle here, kind of at the top left, that is the total number of cases reported. So this should be, for example, in this form, since it's 2017, the total number of cases you had in 2017. In this case, it is 6. And then these are the 3 different columns that I mentioned. In the follow-up email, I detailed how many cases need to go into each column. So that is where this is coming into play. And note that these top numbers here, these 3 circles in the top row, they should add up to your total number of cases reported. You're just kind of splitting them out into your smear positive cases, smear negative culture positive cases, and then basically everything else. So that is what the email detailed, if that wasn't clear. Again, if you have any questions, you can let me know. But that is what we tried to help you all out with there. And then from there, you're just working your way down like this blue arrow is indicating. So you're starting with those cases and just kind of answering the questions as they go down the sheet. And that is pretty much it. So the RP form, going back to your memo here, that's going to be due February 4th. So just about a month and a half away is when we're asking for those. And several of you have actually already sent in your RP form. So thank you so much if you've done that already. When you do send it in, I'm going to shoot you an email and let you know that we got it. I believe all 3 of those have been sent by actual mail so far. So I just wanted to make sure that you got confirmation that I received it. So we'll hit these upcoming for 2019 updates before we get to questions. So before I turn it back over to Emily, we wanted to let some of you all know that we are working on some 2017 data profiles for our highest incidence jurisdictions from 2017. It's kind of a new thing that we're doing, but in an effort to get more data and information out to the jurisdictions who really need it the most, we've put together these profiles. So they are still being developed and worked on, but you can expect those here very soon. So if you are a high incidence jurisdiction, be expecting that. So I'm going to turn it back over to Emily for some of our 2019 strategic planning. Yeah.
Thank you, Charlie. So you got your little Christmas present, as Teresa Goins used to call it, for your year-end data memo. And we're really trying to streamline everything that we're doing with the program. So coming up, we will be sending out a training calendar for 2019. You would find that information in our newsletters. Well, we've gone to just a biannual newsletter rather than a quarterly newsletter. So we're going to send out just that document of our upcoming trainings. Whether or not we've got those training dates, because sometimes it takes a little while to make sure those locations are secured and everything, you will get at least a to be announced. So kind of a save the date, or to know that in the spring, in April, we are planning our physicians and clinicians training. We will be having our 101 orientations for new local health department TB coordinators. So we're excited to get that out. Ruth will be sending that out after the first of the year. We are moving forward with latent TB infection, social awareness, media campaign. You know, that's our prevention, right? If we can prevent TB cases, how do we do that? Well, we need to get some information into the hands of our partners to treat LTBI. That's how you're going to prevent your cases. So we're working very much on that and some reporting elements for that as we move along. And then also, we're entering our 5th year of our grant cycle. So we've got some planning to do for the next 5 years. You know, everything from the trainings that we're going to have, our data. And you know me from being a quality improvement background, work smarter, not harder, right? And so we're really looking at everything we're doing, hence the electronic package this year and not a hard copy package. What I would like to say also, because Charlie won't say this, he's not going to toot his horn, but you know, when he started in July, he hit the ground running. And one of the first things I said to him was, you know, Charlie, I've had to fill in some epi duties, never having to have done that before. And I had to do the ARPI coordination last year. And when I did that, and Charlie, if you'll pull up that ARPI form real quick for me, go backwards for me and show me. There we go. So when I did that, I was like, oh my goodness, this form is not user friendly, and how you all were having to do that is beyond me. So I said, Charlie, first thing we need to do is change the form. And he has done that for you all, because like he said, he's going to submit the state final report. But what you all need, you need to know. You've got to have a user-friendly form so you know what you're doing, because we got so many phone calls last year because we've had a lot of turnover in the health departments, and we recognize this. So what you will see in this section under Part 1, we've added like total number of cases, total number of contacts, and then we did some bulleting just so that you could recognize that this whole form is reporting on contacts. Yeah, we need to know your cases. Yeah, how many were reported as LTBI, but did those that were reported as contacts, did they receive their treatment, and did those contacts, you know, future cases, receive that treatment and complete treatment? Okay, so that's what this form is about. And then, like he said, we eliminated all of that section on the bottom that had calculations that we did on our end. And people were calling me, Emily, I don't know how to fill that out. I don't know what to do on that. That's okay. Don't do it. We'll do it. So we just eliminated it from you. So we know we're not the only program where you have year-end data reporting. And how can we make it easier for you all? So we're excited to have Charlie on board. You'll be talking to him. You know, if you need, have new employees that need TB NEDS access, contact Charlie. He'll get the paperwork to you, and we'll get you set up. So thank you all so much. We're excited, and we hope to hear from you soon. No questions. Okay. So no questions. Thank you all.
Thank you, Emily and Charlie. Great job, yeah. And again, I wanted just to apologize that on your TV packets, I'll get those out ASAP, hopefully today, if not today, tomorrow. So you all will have in your hands, if you haven't already received your TV packet of information, you'll have that for, today or tomorrow moving forward, so you can go ahead and start on your data collection and submission to Charlie. Okay, all right. So next, I'd like to invite Peggy Cook and Kelly Harris to come up. Oh, okay. Telly and Peggy are both with the HIV/AIDS prevention program with the Department for Public Health. It's right here, both. Yeah. Perfect. Thank you. And so Peggy's going to talk to us first about the new HIV documentation form and the evaluation piece of that. And Peggy, thank you so much for being with us here today.
Thank you.
I know that I believe Gail first spoke with us back in the August Public Health Nursing webinar about the new HIV form that was forthcoming. And then she provided a presentation in, August, September. In October, she was on the agenda and spoke in October. And so here we are in December with some follow-up questions and FAQs that you all may have received from the field. And you're going to be speaking about Evaluation Web. And so thank you so much for being here with us so much, Peggy.
Thank you.
And then if you'll go ahead, and when you're done, we'll go ahead and switch over to Telly and let him talk about about PrEP, HIV PrEP, which is a huge up-and-coming initiative with the HIV/AIDS program. And we're so excited to have Telly be here with us today to talk about PrEP. And he is the MSM coordinator for the HIV/AIDS program. So thank you, Telly, for being with us here today. All right. So Peggy, all you'll need to do is just advance your slides. Just hit that arrow,
Okay, thank you so
And
much.
here's your camera right here.
Thank you, Joey. Thank you so much. Good morning, everybody. How are you all today? This new template went into effect 11/1/18, and we've had several questions and concerns over this. So hopefully after today, after I go over this new template, I'm going to go over each section per line and explain the information that we're looking for you to complete it with. And so if you have any questions, please feel free to ask, and we're going to get started. So on section 1, agency and client information, we're going to complete this for all persons, including HIV negative and positive. So on the first line is the session date. We are going to fill in the date of the session in the following format. Month, date, and year. Must be 2 numbers for the month, 2 numbers for the date, and 2 numbers for the year. You must use zeros for all single-digit months and days. Okay, on the program announcement, you're going to use PS 18-1802 unless otherwise instructed. This is the program that CDC recommends. On the agency name, this is where you're going to write in the name of your health department or agency. Under site name, you're going to enter the county in which the health department or the agency is located. Under site type, this is the codes that's on the template, and for all the health departments, you need to use F02.051. And if this is a mobile unit, please use F40. Under site zip code, use the site code assigned to your health department. Under site county, use the county where your health department is located. Under local client ID, always leave this blank. No information is required. The year of birth, there should never be an unknown. If it happens to be an unknown, please write 1800. Section 1 is continued. Under client county, this is where you're going to enter the name of the county where your patient or client lives. Client zip code, please enter the zip code where your patient or client lives. Under client ethnicity, fill in the circle that best describes your patient or client. Client race, place an X in all the boxes that apply. Under client assigned sex at birth, fill in male or female as reported by your patient or client. Under client current gender identity, fill in the circle that your patient or client identifies as correct. Has the client had an HIV test previously? Fill in the response as reported by your patient or agency. Going to section 2, the final test information. Please complete for all persons. Line 1, HIV test election. Fill in the circle describing your testing election. Under test type, this section is divided into CLIA, wave point of care, rapid test. Select one option. Okay, we have INSTI. This is a high quality 60-second test that we are transitioning to for better results. And there's also SureCheck. Under the laboratory-based test, we have blood draw. This is sent to the lab for testing. The result provided to the client. The test result should always be provided to the client. CDC only wants the final test when using the rapid electrogram. Your report will be for the second rapid test. This is when you're testing for those that came back positive. We only want the final test on the second test result for those tested positive. Under Section 3, this is for the those patients or clients that have tested negative only. So under number 1, is the client at risk for HIV infection based on your risk assessment? Number 2, was the client screened for PrEP eligibility? The CDC recommends patients or clients be screened for PrEP and referrals made as appropriate. Number 3, is the client eligible for PrEP referral? See the materials that we sent previously to you. And if you still have any questions on PrEP, then you can contact Telly Harris and he will be glad to help you out. Was the client given a referral to a PrEP provider? Please mark the appropriate circle. Was the client provided with services to assist with linkage to a PrEP provided? Please mark the appropriate circle. Moving on to Section 4. This is only used Section 4 only if your client or patient test is positive. So, number 1, did the client attend an HIV medical care appointment after the positive test? Mark appropriate response. Under date attended, if you don't know the date, put 01/01/1800. Has the client ever had a positive HIV test? If you answer yes, then enter the date of the first positive result if known. Again, if you don't know the date, put 01/01/1800. Number 3, was the client provided with individual behavior risk reduction counseling? Mark the appropriate response. Number 4, was the client's contact information provided to the health department for partner services? Mark the appropriate response. All patients, clients with a positive HIV test result must be referred to partner services. The tester should explain that positive or the PS are offered to individuals who are infected with STDs to their partners and to other persons who are at an increased risk for infection in an effort to prevent transmission of these diseases and reduce suffering from their complications. What was the client's most severe housing status in the last 12 months? Mark the appropriate circle. If the client is female, is she pregnant? Mark the appropriate response. If you answer yes, provide appropriate response for each drop-down box. It is critical for pregnant women to be tested. The CDC recommends those testing positive begin taking HIV treatment for the woman's health and to prevent transmission to her unborn child. The CDC is promoting the One Test, Two Lives campaign. Jamie McLemore, our program coordinator with HIV/AIDS section, is in charge of this new program. So for further information, you may email her at jamiemclemore@ky.gov, or her phone number is 502-564-6539, extension 4284. Section 5, additional tests complete for all persons, whether negative or positive. Was the client tested for co-infection? Mark the appropriate response for each named test. If a client patient declines to be tested for HIV, but wants to be tested only for STIs, you do not complete the HIV test template. If you answer yes to any of the co-infections, please hold the Evaluation Web HIV test template until you have the final results from the STD test, provided when the individual tested for HIV. Once you receive the results, mark the test type and the appropriate result. Then please send to the HIV section, 275 East Main, HS2 E-C, Frankfort, Kentucky, to the attention of Kay Loftus. Note, when you test someone for an STI other than HIV, do not send the results or the EPI 200 form to the HIV section. The EPI 200 form should continue to be sent to the STD program, 275 East Main, HS2 CC, Frankfort, Kentucky. Attention, Chang Lee or Sherry White. You may also fax the EPI 200 form to a secure fax number at 502-564-5715. Section 6, Prep Awareness and Use. Telly Harris will be explaining that section. And then under Section 7, Essential Support Services, after Telly Harris gets done explaining Section 6, then Gil Yoakum is going to explain Section 7. We're going to go ahead and we're going to skip to Section 8, Local Use Fields. This is optional. We are using Section 8 for those people that are using the testing on the syringe exchange program. Under local use field number 1, if the testing occurred at a syringe exchange program, not a mobile unit, write in SEP. Under local use field 2, indicate the name of the rapid test, either INSTI or SureCheck. Or Quick HIV Rapid should not be used at this point. Under local use field 3, the CDC mandated targeted testing data. If you are providing testing to individuals who just walk in and request the test, enter 01. If you are targeting individuals from certain demographics for testing, enter 02. Under Section 9, Health Department use only, we are not entering information into Section 9. This section will be completed by the State HIV Prevention Program staff. Under closing remarks, please use the 2018 Evaluation Web HIV test template that states revised 9/24/18. This will be at the bottom of the form on the first page. The form ID at the top of the HIV test template, this is where you're going to put your white sticker that you received from Kay Loftus. If you need additional sheets of the white stickers, then please contact Kay Loftus. Please do not duplicate your stickers. Please turn in your HIV test forms prior to November the 1st, 2018 in order to receive credit for your county, and the data be entered into Evaluation Web before December 31st, 2018 for the end of the year report. Again, if you have any questions in reference to the new HIV test template, you may email me at peggy.cook@ky.gov or contact Gail Yoakum at gail.yoakum@ky.gov. Or if you have any questions concerning PrEP, contact Telly, T-E-L-L-Y .Harris, H-A-R-R-I-S, @ky.gov. We appreciate your patience while working through this transition. Thank you.
Thank you, Peggy, so much. I have a question for you. Local health departments, we've sent out and posted, but not we've sent out, we've posted through Train your PowerPoint presentation
Yes.
that you've just covered. It's an excellent PowerPoint. Thank you
Thank
very
you.
much for that guidance and clarification on the new documentation tool. So local health departments, if they have questions, would you recommend that they print that off and use that as their?
Absolutely, absolutely. By me explaining section, each line, I think this will really help them a lot when they're completing HIV test form.
I agree 100%.
Yes,
So that's a great
absolutely.
tool. And so
Absolutely.
if you all are from local health department side, everyone, if you'll go ahead and when you've registered for the course, all the documents are there on the train website, the train site, that the course for today's course number. And so if you'll download Peggy's document, PPT document, then you'll be able to have that as a reference tool and as a guidance document when you complete those forms. And feel free to share that with your other staff who might complete those documents as well, so everybody can kind of be on the same page as far as completing that new documentation tool. Okay, then we're going to turn the camera over to Telly. Thank you, Telly.
Thank you. Hello, good morning. Well, almost afternoon. As Peggy said, that I will be.
We're gonna get you on the camera here, sir. Okay.
One moment.
One moment. I want to get Telly on the camera here. Let me see if I can figure that out.
More dirt.
That's right. There, oh, look at here. I got you, Telly.
There he is.
There he is.
Oh, Lord.
Okay. Now let me see here, Telly. Do I know how to get this over? Whoops. There we go. So then how would I move that over? And there's, yeah. Oh, Telly's he's got the camera. He knows exactly where the camera is. I'm just trying to get rid of that little dashboard right there.
I don't mind that.
Can we get that off the screen? Okay. There it is. Now y'all can see Telly all by himself without the dashboard.
All right. I'm going to be talking about PrEP. As we know, it's pre-exposure prophylaxis. The brand name is Truvada, which is intracytidine as well as tenofovir, the medication. And we sent out a PrEP starter kit through the nursing network emails. But this is just going over a little bit of information as to when you're initiating it with your clients and your patients and so forth. Things that you need to know about the indicators. PrEP, we know when it's used in daily use, it reduces the risk through sex of contracting HIV up to 90%. Through injecting drug use, it can be up to 70 or more than 70% reduction rate. And when you combine that with condom use and other prevention methods or so forth like that, you can maximize even more with the resistance and the possibility of contracting HIV. It's a couple of things you want to look at that the CDC has indicated as indicators that your clients have substantial risk of contracting HIV on those aspects. Thank you. It's a couple of things that the CDC PrEP guidelines have said populations you should look at. Really, all populations now they're looking at if you have any type of substantial risk from men who have sex with men, or we abbreviate that MSM, heterosexual men and women, people who inject drugs, as well as trans men, trans women who also go in the category, as well as non-binary identifying individuals. When you're looking at detecting risk of acquiring HIV, you have to look at a couple of things. Some of the things are similar when you look at the different populations, and those populations are the men who have sex with men, the trans man and women population, as well as the heterosexual man and women populations. Those indicators, I'm about to go over right now, that are similar first. In those three categories, the similar identifying risks are sexual partners who are HIV positive, recent bacterial STD diagnosis, a higher number of sexual partners, a history of inconsistent or no condom use, as well as commercial sex work. And for heterosexual men and women, also living in high prevalence areas, our networks can be an indicator as well. Also, when you look at something that's different for people who inject drugs is you're also going to look at, do they have an HIV positive partner that injects drugs? Are they sharing injection equipment? That's also key for transgender individuals as well that may be injecting hormones and stuff, because they have injection parties or different types of parties where they might inject hormones or other substances. And then you're also going to look at, for injection drug users, recent drug treatment, and if they're currently injecting drugs on those aspects. So if any of those categories your patients identify with, those make them at a substantial risk to be considered for PrEP. Now you have clinical eligibility as well. For clinical eligibility, you have to look at a couple of different things. They have to have a documented HIV test before prescribing PrEP, no signs or symptoms of acute HIV infection, and normal renal function, and no indicating medications, I'm sorry, and documenting HPV, hepatitis B virus or vaccination status. You need that as well. It's key to note on certain things, especially with the transgender community. If it's a trans man, it's important to also look at to screen them for pregnancy as well, especially if they haven't had the gender affirming surgery or so forth like that, and they are still having sex with cisgender men. As well as when it comes to the if they're on testosterone or so forth like that, the renal testing, the creatinine testing that you have to do, the serum testing, might be altered from that aspect. So you have to use the same standard of that of a cis male when looking at those type of functions, so that you can adequately prescribe PrEP or consider them for PrEP on those aspects. As well as with transgender women and so forth like that, and people that have had the gender reaffirming surgery, the frontal surgeries and so forth like that, even when they've had the vaginal reconstruction or so forth, although that tissue is considered to be a little bit tougher, it does not naturally lubricate. Therefore, it can have a higher risk of tearing and ripping during sexual interactions and so forth like that. So those are things to consider, those type of conversations, and that's why we stress the importance of having a sexual screening and conversation with all your clients, but be culturally competent and empathetic to where people are, because especially with the transgender community, they have had some rough interactions with medical staff from misidentification and stuff like that. So ask them to be as forthcoming as possible with those aspects so that you can consider them appropriately on those aspects. A lot of people think that PrEP is just take the pill and it's fine. It's not. It's actually like a program. So it's when you prescribe the medication or so forth like that, you want to prescribe in a 30-day increment to a 90-day period, because after that there is still a follow-up process. You have your initial baseline testing, which we again said was HIV testing. Usually you want to use a rapid HIV test, usually a 4th gen, or you can do the pooled HIV RNA testing or so forth. You do your creatinine test, your hepatitis B surface antigen test, as well as your STD baseline test. And if the woman, a pregnancy test for women, especially if they're in a serodiscordant relationship or have a relationship with someone who's HIV positive and they have plans of having a baby or trying to have a baby. So you want to combine that with their prenatal care and have those conversations. The conversation is very important to discuss with your clients that are in consideration with the side effects, possible side effects of PrEP, which certain side effects from studies have shown nausea, which is usually within your first few weeks, it fades away, mild worsening of kidney functions, which can be improved if they have to discontinue from Truvada or PrEP. And it's, you note from your follow-up test that you will continue to do these tests on their kidneys, because at some point you have to pull your client away from the medication for their best health. That is one of the considerations. Also, it has been a decrease in bone density that has been seen in the past or so forth like that, but not an increase in bone fractures or so forth. So discussing those type of risks and benefits with your client is very important before prescribing PrEP on those aspects. Usually once you first initiate and they pass those screenings or so forth and you prescribe PrEP, you have a 30-day follow-up where you assess the side effects with the client, the patient's interest in continuing, adherence counseling. You reinforce the importance of daily use because the more misses they have, the higher risk of contracting HIV, and address challenges the patient is facing. Every 3 months, you will do lab work, continue to do STD screenings and so forth like that. And eventually, over time, you could do a 6-month period follow-up or so forth. But you will continue to need to have those type of support systems there available for them and leakage possibilities. If a client does become HIV positive while on PrEP, you would discontinue PrEP immediately, order and document results of an HIV genotype, the resistance test, and report it to the local health department or yourself or us here at the state as well. And ensure that they're linked to the HIV primary care facility to initiate antiretroviral therapy. I know a lot of people ask and have been asking about the billing aspect and PrEP. Most insurances and Medicaid does cover PrEP. They still have some of their own rules on those aspects, but there are a number of assistance programs for the insured and uninsured out there. Truvada themselves has an assistance program to help pay for labs and co-pays as well. That was sent in your packet. If you did not get that packet, PrEP starter kit packet, email me or Joy, and we can get that to you as well. And I'm also going to be sending out an email which is going to cover a packet that is billing coding for HIV prevention, which will cover PrEP, the screening and linkage services assist that go hand in hand with PrEP as well, so that you'll have those codes to assist with those type of needs. And that's it for me. Thank you. Any questions?
Yeah.
I don't know where to look at them.
I have one, Kelly.
Mhm.
If a client initiates PrEP therapy prior to them, and they're on PrEP therapy and they become infected with HIV, does the PrEP therapy, does that prolong or mitigate the need for antivirals? I mean, does that help as far as if they're already infected, once they get infected with AIDS?
No.
HIV, excuse me.
No, so you'll have to, like I said, they'll have to change because the PrEP is just a combo. It's a 2 medication. They have to go to a 3 medication cocktail,
Okay.
and that's why they're going to do that initial test again, that a resistance test or so forth.
Gotcha. So, but they still stay on the PrEP?
No, they'll discontinue the PrEP altogether, and that new test will determine what medications work best
Okay,
for them.
all right, that's the part that I missed. Thank you very much for that
All right,
clarification.
no problem.
Okay.
Any other questions? Are these all the questions?
Yes.
Oh, previous question regarding section 5. What sample is not sufficient? Are these questions? If we go off-site to a college campus to test high-risk groups, do we still need it? These are for the test run. Test site. Is there a list? Okay, so is there a list for PrEP providers in Kentucky that we can provide to local health departments? You have PrEP Locator, which was also sent out, where you can you're looking there, put in a zip code that you are looking for a PrEP provider in, and it'll tell you the PrEP providers in that area. It's a large number of them. Some areas do not, but if you are a doctor or a facility that wants to start prescribing PrEP, we recommend that you go on PrEP Locator and register so that people can look on there and find people in their closer vicinity to get that. But I will work on, I construct a thing and send out so that you will have a local list. But it's a continual growing list, so that's why we always say PrEP Locator.
And that the PrEP Locator information Was that included in the package?
Yes.
So again, I think that's a great point, Kelly. So to reiterate, that information is in the prep packet that they were sent. And if they need that packet information resent to them, you'll be more than happy to send that to them, or the email would have come from me. And I'll be glad to resend that to the nurse on the program's behalf.
For the result, what if the sample was not sufficient and you do not have a result? In most cases with HIV testing and so forth like that, if the sample was not sufficient, you would retest. See if they're willing to do the retest or so forth like that. Do another draw if it is a blood draw, another finger prick if it's that. That's your number one go-to. Just ask to retest. We have some questions regarding testing.
Did we answer all,
That's for the form.
the site type? Okay. So you answered all of your questions, Kelly, on
Yes.
there? Okay.
Oh, you couldn't hear my voice. I'm sorry, Paula Watson.
For the site type question, let's answer Dorothy's question while we've got Peggy still here in the room. This question is, oh, I'm sorry, Gail, you gonna discuss that?
I can.
Okay.
Well, next we have Gail Yoakum that's going to discuss essential support services, as well as she'll answer some of the questions with your forms. Thank you.
What questions?
Oh, I can bring them back up.
Yes.
Okay.
Yeah, that's fine. Okay, I'm Gail Yoakum, and thank you for having us with you today. And there is a question: if we go off-site to a college campus to test a high-risk group, do we still use F02.051? That is the code for the community health center. And if you are going off-site, if you look at the bottom of the form where it has non-clinical sites, you would look at, over on the right-hand side, look at that listing and pick the most appropriate site. And the site is F02.5.1 Community Health Center, which is what we use for the health departments. So I think we've got all the questions. And I'm going to briefly just talk about section number 7, Essential Support Services. And for the first 3 of those are for positive clients only. And navigation services for linkage to HIV medical care. If the individual tests positive, you're going to determine with that patient or client if they have a medical provider, and if not, then you would mark yes for need determined, and then assist them with finding a medical provider, either someone at the health department who could see them or an infectious disease physician in their area. Linkage services for HIV medical care. Those are services that help the HIV positive individual to meet their basic needs and to get their medical care covered, whether that is providing insurance for them or helping them to sign up for insurance, or to be able to find other medical services for other complementary conditions that may be involved. For those health departments or health districts who have linkage navigators, these folks are going to be invaluable to you in helping that individual who tests positive for HIV to navigate the system and to get linked up for insurance and other services for which they're eligible through the Ryan White program. Medication adherence support. Taking pills is not the greatest thing in the world for some people, and they have a hard time being on a schedule for taking their medications. Now there are a lot of pharmacies that will put medications for the day in a pack that you might have access to in your area and could refer that patient or client to that particular pharmacy to access that service. The bottom ones are for all clients: health benefits, navigation, and enrollment. If you have a patient or a client who comes in to see you and they don't have insurance, we need to help them to learn about the health market so they have the opportunity to look at the different benefit plans and to sign up for one if they so choose. Evidence-based risk reduction interventions, these are primarily for the community-based organizations who provide programs for high-risk individuals and HIV-positive individuals. And some of those programs are Healthy Relationships, CLEAR, Promise. Those are effective scientific-based interventions that help individuals to deal with their status or their high-risk behaviors and hopefully to help them to lead healthier lifestyles. Behavioral health services is where you're dealing with issues related to the person's well-being, ability to function in their everyday lives, and their concepts of self. So a lot of times when you're working with a patient or a client, they may share information with you about other lifestyle issues that are affecting their health, such as substance use. They may be depressed or anxious, or you may notice signs of attention deficit disorder. In those cases, you would mark, if you notice those things, that you've screened for those and that you've determined that there is a need for the client to seek further assistance, and whether or not you provided that service or referred them onward to, say, a community mental health agency or substance treatment area facility in your area. And social services, that's something I'm sure you deal with and assess for every day. Does the family have need for clothing, food, shelter, those basic needs? Do you suspect that there may be domestic violence issues going on in the family? Or are there child protection issues? And if any of those things are present, then of course you would make a referral to your local Department for Community-Based Services office. So I think we've covered all the form today, and many thanks to Peggy and Telly for their detailed discussions, and we are here to help you and support you. The form has changed a little bit, but CDC is trying to gather more information about the client population that we're serving, so we can make sure that our programs are geared and targeted toward those needs. If you all have any questions, if you need any educational materials, just reach out to us here in Frankfort and we will be glad to assist you. Thank you.
Thank you so much, Gail, to you and your team for the information, the updates that you all provided for the local health departments today, and all of your support that you all provide. Thank you, local health departments, for all of the services, the HIV/AIDS program services that you provide in your communities through your partners and networks. So next, I'm going to invite Katie Myatt up to the camera. Thank you. Katie, as you all know, is the Reportable Disease Section Manager for the Department for Public Health, and she's going to provide us a hepatitis A outbreak update and discuss the HIV checklist briefly that were sent out earlier this week. So Katie, thank you so much for being with us today. I know you're a busy lady, so thank you.
Switch places. Okay, so the HIV checklist went out to local health departments. Here we go. The better. Went out last week, and this checklist is really just a way for you to generate ideas on how you want to respond to the hepatitis A outbreak. It goes by discipline and phase, so you can pull out your discipline if you, as a nurse, and figure out what you need to do to help fight the hepatitis A outbreak. Then additionally, it's broken down by phase. So if you're not in the midst of the big outbreak, then you can do the first part of the checklist. If you're in the middle of the outbreak, you can do the response phase, and then at the end, when we're done with this, hopefully soon, we'll all do the recovery phase. So within that checklist, we've got links to helpful resources. The Google Drive is linked in there, not only by the overall folder, but then with individual folders within the drive as well. Helpful web links, our outbreak page, CDC's Hep A outbreak page, as well as their regular Hep A page is all linked. So it's a very good resource, and we would encourage you all to look at it just to figure out how you can respond to the outbreak in your community. Additionally, some information went out last week as well, a packet for behavioral health partners. There was a cover letter as well as some materials that can be used in their facilities. And then you all got a map with contact information of where those facilities are in your community. So the information's on the Google Drive if you didn't get it via email, but I'd encourage you to send those packets out to your behavioral health partners. It is intended to go out through the Department for Behavioral Health as well, so we want them to get it not only from the state down, but from the local level up. And then lastly, just an update on kind of the outreach that we've been doing. We spoke with the Kentucky Jailers Association yesterday. Actually, very, very engaged individuals at the end of the day, which was surprising for me. So we had a lot of jailers come up to us with interest in ongoing vaccination efforts at their facilities, increasing their vaccination efforts if they had already done a one-time mass vaccination clinic. And so I would look to hear from them in the near future if you've got a very proactive jailer. And that could be, there were new jailers, so this conference is training for not only existing jailers, but for newly elected jailers. So some of them might not take office until January. I know I spoke with at least one that is a new jailer who is looking to do vaccination efforts when he takes office in January. So just be ready for phone calls if you have any questions on how we can get vaccinations into the jails. I'd be more than happy to discuss them with you. Private stock funding is not the only option. We can use 317 vaccine in the jails. We can sign up jails as 317 providers as well. So there are many, many different options. And if you want to talk through it before you get on the phone with your jailer, we can set up a conference call or do that with however you'd like. Did you have a question?
Yeah, I did. You saw that on my face.
Yes.
So when you spoke with the Jailers Association yesterday, Katie, was your recommendation that they contact their local health department?
Yes.
Okay.
Yes. So it's much easier as far as logistics go if they work through the local health department, and those are your all's partners. So we don't want to get in the middle of a local partnership, and that's really where it needs to be housed anyway. So we push them to you all, and then if you need help from us to figure out how it's going to work, then we're happy to help there too.
And then would you like to briefly just give us the update on the HIV epi curve and what that's looking like?
Okay.
Yeah.
So if you look at the most recent curve in the report from last week, which was through December 1st, October was a really bad month. November, I don't think we'll hit October levels. So it's right back down to where it was in September, August. We're not going down, that I can tell. I just don't think we're increasing at the level we were in October. So it's still going, unfortunately. I'm sorry. Thank you.
Are there any questions for Katie?
I'll come back.
Let's see here just a sec. It looks like it's a Kelly question for PrEP providers. Anything else? Okay.
Perfect.
Thank you, Katie.
Sorry,
Thanks. Yeah, you're fine. You're fine. Thank you so much.
Okay, so that concludes this today's public health webinar. I did want to mention to you that I've gone ahead and identified the 2019 public health webinar dates, and we have the rooms reserved for those webinars for you all. And I will have that calendar ready for forwarding to you all so you all can mark your calendars. I know that you all like to go ahead and get those dates reserved. Wanted to also let you know that I have an announcement, a personal announcement, and a professional announcement. I wanted to let everyone know that I'm retiring. My last working day with the department will be next Friday, December 21st. I'm retiring a little bit early because my family needs me. I'll be assisting with care of a family member. And I wanted to share with you all from the bottom of my heart that working with you all has been the very best part of my career. And I've always tried to be your cheerleader and your advocate, your consultant, your counsel, and from a clinical perspective. And I just admire each and every one of you all so much. It's been a pleasure and an honor working with each and every one of you all. And when I say public health nurses, that certainly includes the Department for Public Health Nurses. As you all know, there's about 50 public health nurses here in Frankfort. And then the greatest population, of course, is out through the local health departments, all of the LPNs and RNs and APRNs that I work with and have worked with since beginning this journey in 2009. So when I hear about the transition, the new points of contact, I'll be certain to let you know. So that process will be happening not only for my duties as the Chief Nursing Officer, but also as the Department CE Coordinator and the Division of Women's Health Division Director. So there's some transitions, assuring a safe handoff of my duties to other folks here in Frankfurt. And again, please know that you all are doing such valuable work each and every day, and I could never do what you all do. And so again, it's been my pleasure to work with you all, and I wish you all the best and Merry Christmas. Okay. All right. Thank you. Thank you. Okay. That was right on time.